कहते हैं सभी महान व्यक्तित्व सरल, ज्ञान के धनी व गुणों के समृद्ध होते हैं.
And today we are very privileged and honored to invite our esteemed guests on the dais. Please join me in extending a warm welcome with a big round of applause for Member of Parliament, Mr. Shankar Lalwani, sir. Honorable Guest of Honor, Dr. Sangamitra Pati, Additional Director General, ICMR New Delhi. Honorable Special Guest, Padma Shri Padma Bhushan, Dr. Ashok Seth, Chairman, Fortis Escort Heart Institute, New Delhi. Honorable Special Guest, Mrs. Sudha Chandran, renowned actress and classical dancer. Dr. Ramesh Dugabhati, Associate Chief of Cardiology and Director of Structural Heart Disease, West Virginia University School of Medicine, US. Dr. Sujata Viprale, Chairperson, WINCARS. Dr. Shiba Chabra, Director, WINCARS. Mr. Abhilash Pillai, COO, Apollo Hospitals, Indore. Dr. Roshan Rao, Senior Cardiologist, Director, Cardiology, Apollo Hospitals. And the soul of the conference, Dr. Sarita Rao, President, WINCARS.
Thank you so much, all the guests, for your gracious presence here on the dais. In India, a guest revered with the stature of the divine, and today we are blessed with the opportunity to welcome and honor such radiant personalities among us. Ladies and gentlemen, firstly, I would like to request President of WINCARS, Dr. Sarita Rao ma'am, to kindly welcome our honorable chief guest, Member of Parliament, Mr. Shankar Lalwani ji. Ma'am, please. Now I'd like to request Dr. Sarita Rao ma'am to kindly welcome our honorable very special guest, Mrs. Sudha Chandran ma'am. Now, once again, I'd like to request Dr. Sarita Rao ma'am to kindly welcome our honorable guest of honor, Dr. Sangamitra Pati ma'am, Additional Director General of ICMR, New Delhi.
संगमित्रा मैम का
अशोक सेठ हो गया पर देना पड़ेगा.
Now, once again, I'd like to request Dr. Sarita Rao ma'am to kindly welcome Padma Shri Padma Bhushan Dr. Ashok Seth sir.
I now request Dr. Shiba Chabra ma'am to kindly facilitate Dr. Sujata Viprala ma'am. Can't help it. कोई बचा तो नहीं है वो डॉक्टर का I request Shiva ma'am once again to kindly felicitate Mr. Abhilash Pillai, sir. अभी करिए, फोन करिए। आप करोगे या आप करोगे? रमेश जी, रमेश जी। नहीं दिया दिया ना? I request Dr. Sarita Rao to kindly felicitate Dr. Ramesh Dugubati, sir. I request Dr. Shiva ma'am to kindly facilitate Dr. Roshan Rao, sir.
शंकर बालकनी सर का मैं लेके बैठी हूँ स्पेशल गेस्ट ठीक है लालवानी सर का
I request Dr. Sarita Rao ma'am to kindly give this special guest memento to Shankar Lalwani, sir.
Thank you so much, everyone. Thank you. सरस्वती महाभागे विद्ये कमल लोचने विश्वरूपे विशालाक्षी विद्यां देहि नमोस्तुते.
It is said that darkness cannot drive out darkness. Only light can do that. And we believe that in the darkest of the times, just a lamp can bring hope and guidance.
आइए हमारी संस्कृति और परंपरा का अनुसरण करते हुए निवेदन करना चाहेंगे हमारे कार्यक्रम के समस्त अतिथिगणों से कि वे दीप प्रज्वलित कर कार्यक्रम का शुभारंभ करें. सो प्लीज.
I would also like to invite Siddharth Bhargav sir, Dr. Kshitij Dubey sir and Dr. Vikas Gupta to kindly join the dais for the lamp lighting ceremony. Requesting Siddharth sir, Kshitij sir and Dr. Vikas Gupta sir.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर
Thank you so much, our honorable guest. Ladies and gentlemen, कहते हैं बिना मेहनत के हासिल तक तो ताज नहीं होते, ढूंढ लेते हैं अंधेरों में भी जुगनू अपनी मंजिल, वो कभी रोशनी के मोहताज नहीं होते. It says that true success demands consistent effort, and those who rely on their inner strength can overcome any adversity and accomplish wonders. Today, we have one such amazing personality with us as our chief guest. So I request our honorable guest, Member of Parliament, Shankar Lalwani sir, to bless the occasion with your kind words. So please.
धन्यवाद. धन्यवाद. हेलो, माइक सही हाथों में था. धन्यवाद. मंच पर उपस्थित सभी अतिथिगण, यहाँ उपस्थित सभी डॉक्टर, सबसे पहले मैं सभी अतिथियों का द क्लीनेस्ट सिटी ऑफ द इंडिया इंदौर में स्वागत करता हूँ, वंदन करता हूँ, अभिनंदन करता हूँ. मुझे जब इनविटेशन मिला तो पहली बार मैं पार्लियामेंट चल रही थी, लोकसभा में था और कल रात को आया, तो मुझे जब इनविटेशन मैंने देखा तो मुझे इतनी सारी डॉक्टरों की कॉन्फ्रेंस में जाने का मौका मिलता है, लेकिन वुमेन कार्डिक कॉन्फ्रेंस ये पहली बार मुझे मौका मिला है इस आने का. तो मैडम राव, आपको धन्यवाद कि मुझे लगता है इंदौर में पहली कॉन्फ्रेंस है वुमेन कार्डिक की सो फार इंदौर कंसर्न. पहले हो चुकी है तो ओके. तो सभी अतिथियों को जो बाहर से आए उनका स्वागत करता हूं. और मैं वैसे डॉक्टर तो हूँ नहीं, डॉक्टर तो सब मंच पे बैठे, मैं इंजीनियर हूँ, लेकिन ये बात सही है कि वुमेन कार्डिक में बहुत कम डॉक्टर मिलते हैं. पहले खास करके गायनिक हो या पेडियाट्रिक हो, बच्चों के हों, उसमें वुमेन डॉक्टर मिलते थे. लेकिन अब मैं देख रहा हूँ, जो भी मैं बात कर रहा था मेरे डिप्टी डायरेक्टर से, तो बोले वुमेन भी आजकल कार्डिक में बहुत सारी हैं. और अच्छी बात है कि इस क्षेत्र में हमारे वुमेन डॉक्टर भी है कार्डिक में. और ये भी सही है कि कार्डिक प्रॉब्लम अभी वुमेन्स को भी बहुत आ रहे हैं. पहले ऐसा लगता था कि मेन जो मेन है उनके ऊपर ही प्रेशर रहता है, उनको कार्डिक ज़्यादा रहता है. लेकिन जिस प्रकार से वुमेन अभी जिस सिचुएशन में रहती है, घर भी संभालती हैं, बाहर भी संभालती है, परिवार को भी संभालती है, वो भी बहुत स्ट्रेस में रहती है. तो उनका भी कार्डिक मुझे लगता है कि चेकअप समय समय पर होना चाहिए और उसके लिए वुमेन डॉक्टर होना बहुत अच्छी बात है. तो मेरी ओर से शुभकामनाएं हैं इस कॉन्क्लेव को, और आने वाला समय बेहतर हो सबके लिए. हम चाहते हैं कि प्रिवेंटिव हेल्थ केयर की बात करें. माननीय प्रधानमंत्री जी ने बात कही है कि प्रिवेंटिव हेल्थ केयर को लेके हमें जन जागरण करना चाहिए. ऐसी नौबत ही नहीं आए कि हमें डॉक्टर के पास जाना पड़े. सॉरी डॉक्टर, सभी के लिए डॉक्टर के पास जाना पड़े. तो प्रिवेंटिव हेल्थ केयर को लेके बहुत सारे इनिशिएटिव हुए भी हैं. सरकार भी इनिशिएटिव ले रही है कि प्रिवेंटिव हेल्थ केयर में होना चाहिए. क्योंकि जिस प्रकार का अभी एक हमने भी इंदौर में सर्वे किया था, हमने नॉर्मल जो अपने आप को फिट समझते हैं उनका एक सर्वे, मेडिकल सर्वे किया था. अभी हमारी मेडिकल के डिप्टी डायरेक्टर बैठे हैं, उनको बता दूं कि दुनिया का इंदौर एक ऐसा शहर है जहां 4.5 लाख लोगों का मेडिकल सर्वे हुआ. और सरप्राइजिंग ये है कि 48% लोग ऐसे हैं जो अपने आप को ठीक समझते हैं, उनका कोई ना कोई पैरामीटर अनफिट था. तो हम भी बहुत बड़े हुए कि ऐसा क्यों हुआ. तो जब मालूम पड़ा कि जो लाइफस्टाइल है हमारी, वो लाइफस्टाइल कहीं ना कहीं मेडिकल रिपोर्ट अनफिट कर रही है. तो अब हम वेलनेस सेंटर की ओर जा रहे हैं कि बेहतर लाइफस्टाइल हो, जिस लाइफस्टाइल के कारण अब बहुत सारे इशू आ रहे हैं, खास करके कोलेस्ट्रॉल बढ़ रहा है, शुगर हो रही है. और यंगस्टर में हमने भी देखा कि किस प्रकार यंगस्टर जिम में जाते हैं और वहीं कोलेप्स होते हैं, शादी में नाच रहे हैं, कोलेप्स हो रहे हैं. ऐसे बहुत सारे इंसिडेंट हुए हैं. तो कहीं ना कहीं हमारे लाइफस्टाइल को बेहतर करने के लिए मुझे लगता है कि प्रिवेंटिव हेल्थ केयर को जाना चाहिए. और ये प्रिवेंटिव हेल्थ केयर सरकार की भी प्राथमिकता है कि भले ही हमें कुछ ना हो, लेकिन समय समय पर हमें प्रिवेंटिव हेल्थ केयर करना चाहिए. और दूसरा, सरकार ने ये भी आभा कार्ड को लेकर भी अभियान चलाया है कि आभा कार्ड को लेकर हमारे सब में आभा कार्ड में रजिस्ट्रेशन भी होना चाहिए. कहीं कोई इमरजेंसी रही तो आभा कार्ड से हम ब्लड ग्रुप वगैरह सब चेक कर सकते हैं. तो ये भी हम इनिशिएटिव इंदौर वो शहर है देश का जिसने सबसे ज़्यादा आभा कार्ड बनाए हैं. तो इंदौर हर क्षेत्र में आगे है, चाहे क्लीनेस हो, एयर इंडस क्वालिटी में हम बेहतर हैं. नेचुरली एयर इंडेक्स क्वालिटी बेहतर रहती है तो स्वास्थ्य में भी बेहतर रहते हैं, उसमें भी हम नंबर 1 हैं। तो मैं इस कॉन्फ्रेंस की शुभकामनाएं देता हूं और यह आयोजन और आगे मेडिकल में अपना एक पाथवे बनेगा, ऐसी शुभकामनाएं देता हूं। बहुत बहुत धन्यवाद।
थैंक यू सो मच सर। निश्चिंत ही आपके मार्गदर्शन में इंदौर स्वच्छता के साथ साथ स्वास्थ्य में भी नंबर 1 बनेगा। थैंक यू सर।
जिंदगी की किताब में कुछ पन्ने ऐसे होते हैं जो हमें साहस, संघर्ष और सेवा का असली अर्थ सिखा जाते हैं। So to introduce our special guest, we would like to invite the lifeline of Dr. Sarita Rao, Miss Sanvi.
A spirit strong, a will so bright, a woman who turned her pain into strength and light. Please join me in welcoming Miss Sudha Chandran, an internationally acclaimed Bharatanatyam dancer, actress, and an inspiration to millions. Despite facing immense challenges early in her life, she persevered and returned to the stage with remarkable courage and determination. Her incredible journey inspired films like Mayuri and Nache Mayuri, and she has built a celebrated career in television and cinema. Her story of resilience and extraordinary strength shows the endurance of the human spirit. Let us all give her a very warm welcome.
We would like to request you, ma'am, to please grace the occasion with your kind words. Ma'am, please.
Our Honorable Minister, all the dignitaries on the dais, to all the ladies and gentlemen out there, very good evening. It's my honor and pleasure to be here this evening to attend the 18th WCC conference. जैसे हमारे मिनिस्टर साहब ने बिल्कुल सही कहा, मेडिकल ऑर्गेनाइजेशंस और कॉन्फ्रेंसेस मैंने बहुत अटेंड किए हैं, but this is first of its kind. And today standing here, I really feel so proud of the fact that yes, I am a woman, and if given a chance to be reborn again, I want to be born as a woman again. Well, we're talking about a very advanced society today where it's a very fast-moving world, where we thought women were just participants. No longer. Now they are leaders. They have started moving ahead in every arena and breaking those glass ceilings which we thought we could never ever break, just to realize our dreams. And like they say, women, every person has those tiny sparks within them, which we generally tend to ignore, maybe because of our family responsibilities. But अगर उन छोटी-छोटी चिंगारियों को हम थोड़ी सी हवा दे दें, तो ये सुनामी जरूर बन जाएगा एक दिन. And that will be the flame of achievement. I'm always indebted to the medical fraternity, because when I was lying on the hospital bed after the accident, I didn't know what was my next step in life. And I was so fortunate. They say God is not there everywhere, but He places the right people in your lives at the right time. And for me, it has been the medical profession all through my life. When I was lying on the hospital bed, it was Dr. P.V.A. Mohandas, who was the leading orthopedic surgeon in Tamil Nadu, who actually amputated my leg. And for the first time, I saw tears in his eyes. And he said, I'm so sorry. I really don't know what to say, but I think you should not dance anymore. You are not destined to dance. And me being the arrogant me, and I told Dr. P.V.A. Mohandas, Doc, I will meet you 3 years later, and I will send you an invite where you will come and see me dancing on stage. Absolutely not knowing what my future held for me, but somewhere I manifested it. I believed in myself. And so true. In 1981 was when Dr. P.K. Sethi won the Raman Magsaysay Award for the Jaipur foot. And there was his assistant director who came, the doctor who came and told me, he says, Sudha, I think your prayers are answered. They have found the foot for you. So I said, very good. I went and met Dr. P.K. Sethi in Jaipur, and the first thing what I asked him was not, can I walk? the first thing I asked him was, can I dance? And he said, of course you can. Jaipur foot is a kamal ka foot. Don't worry, sab kuch ho jata hai. So I thought, oh my God, if Dr. P.K. Sethi has said this, then it's going to be really easy. But no, it was not as simple as I thought. It took me 3 long years when the stump used to bleed and I felt like giving up. And Dr. Sethi, you rightly said, the family that stands by you solves a lot of problems. Each time I wanted to give up, I used to look at my parents and I said, no, I'm not going to give up because I owe it to my parents. I don't want them to leave this world as unsatisfied souls. And people said it's destiny, it's karma. I said, ये सब कुछ मुझे नहीं पता. At the age of 16, मैंने ऐसी कोई गलत काम नहीं किया है. Then they said it's past life. I said, वो बाद में देखा जाएगा. पहले present life के बारे में सोचते हैं. And that was the time when I went, I got the Jaipur foot and I actually started dancing. And Hindustan में अगर कुछ बहुत जल्दी मिलता है, वो है free advice. People actually walk up to you and say कि क्या ज़रूरत है डांस करने की, अच्छी खासी पढ़ी लिखी हो, पढ़ाई पे concentrate करो. But what I'm trying to say is, what comes easy to you is something that everybody gets it. You have to come out of the comfort zone and try to challenge yourself. I actually challenged myself. Even I was not very sure whether I would be able to dance with an artificial limb. But I believed in my dreams. And like Abdul Kalam sir rightly said, dreams are those which don't allow you to sleep. I didn't sleep for 3 years. I only prayed and prayed and prayed that I had to come back on stage. And I was ready to face all struggles. And I always believe that women are more stronger than the men. This I very strongly assert here. They are multitaskers. कभी उनके चेहरे पे कभी भी शिकंज नहीं रहता. You know, they are always there. They have a smiling face. कितनी भी problems क्यों ना हो, जब पति घर आता है तो they have that beautiful smiling face. ऑफिस में जाते हैं, बॉस कितना भी चिल्लाए, उनके face पे वो smile रहता है. It solves a lot of problems. So maybe that is the reason that we have all come up. But there is a saying which says that behind every successful man is a woman. But I would like to differ and say that behind every successful man, every successful woman, there is a man too. It is the father, it is the son, it can be the brother. Because अगर आज हम अपने घर की दहलीज को लांग कर बाहर आए हैं, आज अगर हमारे सपने साकार हो रहे हैं, we are very thankful to the men in our lives. आज आप लोगों की वजह से the generations have changed. Today the man feels very proud to see his wife achieving a lot of things. In fact, when I met Sarita ma'am yesterday, I was just telling her, the aura that she emits is something which cannot be described in words. And I'm so happy, आज 4% है, वो दिन दूर नहीं है, जब कार्डियोलॉजी में भी या तो हम इक्वल टू मेन रहेंगे या फिर 1% ऊपर ही रहेंगे. डॉक्टर सेठ ऐसे मत देखिए प्लीज. कहते हैं ना, चेहरा क्या देखते हो, दिल में उतर कर देखो ना. लेकिन जैसे आप लोग कहते हो कि दिल बहुत स्वस्थ मस्त रहना चाहिए, वी ट्राई टू बी हैप्पी ऑल द टाइम. बट क्या करें, आजकल तो उठते बैठते सोते जागते ऐसा होता है कि कल जो रात को हमको मिला वो कल सवेरे उठा ही नहीं. वी रियली डोंट नो द रीजन. मे बी इट इज स्ट्रेस. कई बार ऐसा होता है कि वी वुमेन वी ट्राई टू कीप अ लॉट ऑफ थिंग्स विद इन अस. नाउ इज द टाइम दैट वी नीड टू रिलीज इट. एंड वी कैन, द बेस्ट वे वी कैन रिलीज इज when we move towards our ambitions and goals. Like I moved towards dancing and I think dance is the biggest stress buster for me. बहुत सारी चीज़ों को मैं भूल जाती हूँ जब मैं डांस करती हूँ. And being a specially challenged person, I have dedicated my life to work for the specially challenged. मैं जिंदगी भर मैं उनके लिए काम करूँगी क्योंकि ये एक ऐसा समुदाय है जिसे तवज्जो नहीं दिया जा रहा है. There is no representation in the government in a proper way. They need that representation today and I have pledged my life for that community. उसके बाद भी, thank you, उसके बाद also when I came into the film industry, people said this industry is not for people like you. That was another challenge which again I stood against and said, ये आप decide नहीं करोगे कि कौन सी industry हमारे लिए सही है और नहीं है. And God willing, with God's blessings and my patience and will and determination and my hard work, I became one of the leading stars in television. I became a household name. I think from Kahi Kisi Rose, where I played the most negative role, to Nagin, where I tortured the animals also. people love to hate me. Being a very positive person, टेलीविजन में मैं काफी लोगों के दिल को तोड़ती हूँ, इसलिए तोड़ती हूँ ताकि डॉक्टर्स उन्हें जोड़ सकते हैं. Anyway, it was a pleasure meeting all of you, and I'm so happy and privileged to be in Indore, which is, I think, कितने सालों से आप the cleanest city रहे हो. काश हम सब आपसे कुछ सीखे. जैसे मैं मुंबई की रहने वाली हूँ, हर बार जब मैं वहाँ के वो अनक्लीन रोड्स देखती हूँ, आई ऑलवेज से जाओ कुछ तो जाकर सीखो इंदौर से, ताकि हम भी हमारे शहर को खूबसूरत बनाएं. एंड विशिंग यू ऑल अ वेरी हैप्पी गुड़ी पाड़वा, हैप्पी 2026. गॉड ब्लेस ऑल ऑफ यू. थैंक यू.
Thank you so much, ma'am. Thank you so much, ma'am. Listening to your experiences was truly wonderful. And after hearing to you, I just remembered a quote by Michelle Obama. They once said that communities and countries are as strong, they are as strong as the health of their women. So that's why I believe that being a healthy woman is very, 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 very important to a nation and as well as for the entire world.
हर दिन के बाद यहाँ रात होती है, हार या जीत भी सबके साथ होती है. कर ले कोई कितनी भी जुनून से दोस्ती, चमकता वही है जिसमें कुछ बात होती है.
It says that life is a balance of victories and learnings, and true radiance belong only to the genuine inner depth. And it is an absolute honor and matter of great fortune for us to have a very distinct personality with us. And now I'd like to request Dr. Shiva Chabra ma'am to kindly introduce our very special guest, Dr. Sanghamitra Pati ma'am. Ma'am, please.
Humility is the surest sign of strength. And in that 1 minute of interaction that we just now shared, dear ma'am, let me tell you that vibe was transmitted. It's indeed a pride, privilege, and honor to introduce none other than Professor Dr. Sanghamitra Pati. Dr. Sanghamitra Pati is a distinguished physician scientist and public health researcher with over 32 years of experience. In 2000, she was honored with the joint Japan and World Bank Graduate Scholar. Her Wellcome Trust funded research was one of the first in India and other low-income countries. She has had a great impact on multimorbidity in healthcare settings, leading to development of widely adopted MEQ-PC tool. Her work spans over multimorbidity, tuberculosis elimination, including adult tuberculosis vaccine trials, malaria, development of the vaccine for malaria, and long-term consequences of COVID-19. And if I have to read this list of awards, it seems to be never-ending. The Samantha Chandrasekhar Award 2018 by Orissa Bigyan Academy, Devi Award 2020, the President's Appreciation Award 2020 by Indian Medical Association, Times Power Women Award 2021, Madhubhushi Orissa Gaurav Samman Award 2020, Viswamukti Rashtriya Swasthya Samman 2023, Orissa Women Award 2020, Chief Minister's Award for Excellence in Healthcare Services, Government of Orissa 2024, Women Achievers Award 2025, Femina Achievers Orissa 2025, and believe me, the list continues on and on. Ma'am has been recognized as India's most influential researchers. She's listed amongst the top 2 global scientists. We welcome you, ma'am, and it's indeed a proud privilege to have you.
Requesting ma'am to kindly grace the conference.
Once again, good evening to each and one. Congratulations for this event. Honorable MP sir on the dais, Sudha Chandran ma'am, Seth sir, Sarita ma'am, and all the luminaries of cardiology on the dais and off the dais. First of all, it's a proud privilege because जब आप एयरपोर्ट से निकलते हैं, वो साइन बोर्ड पे लिखा हुआ होता है, आपकी स्वागत इंदौर में है, cleanliest city in the India. So congratulations to each citizen of Indore and having this at Indore. All of us we say that clean environment is the path to good health. So इंदौर में कार्डियोलॉजी कांग्रेस करना एक कोइंसिडेंस ही नहीं, एक डेस्टिनी है. And all the women cardiologists, you have added much glamour to already glamorized discipline of cardiology. When we were doing MD, then each one of my fellow classmates' ambition was either cardiology, plastic surgery, neurology. Unfortunately, I couldn't make it to that. I had to be satisfied with the discipline of lab medicine. And when I attended this conference, it's a moment of nostalgia for me. Because my MD thesis was on cardiovascular disease, and at that time, a new concept of postprandial lipemia was being proposed. And my guide told me, you see, whether there is a difference in postprandial lipemia between those who have established cardiovascular disease and those who do not have. Unfortunately, I couldn't continue that research because I had to move, as Dr. said, very articulately highlighted what are the reasons women can't pursue the careers, that few were also with me as well. But at the same time, each one of you who is here, and I was having a very small discussion with Sarita ma'am, and she told a very impressive dialogue which got imprinted. Each woman who is successful has a story to say. And already we heard a very inspiring story, real story in fact, from Sudha Chandran ma'am. I'm sure each one of us not only has been inspired, but also I could see all of us were taken into a state of trance. In fact, I was scared whether I would be able to wake you up or not, because each one of us so mesmerized in her captive speech. Because when real stories get spoken, nothing could touch heart more than that. Thank you, ma'am. I have heard about you, I have seen you, but never ever I got the chance to listen to you, and it was so, so inspiring. I mean, please, may God bless you to continue to inspire all the girls like this. Thank you, Sarita ji, for making this blessed moment happen. I come from Indian Council of Medical Research. And Indian Council of Medical Research is the apex medical research organization of the country. Many of you might have seen the role we played during the COVID-19 pandemic, and how each day guidelines were being changed and how the diagnosis should be made, the kits. So this was a journey which also made us realize the importance of being self-sufficient or Atmanirbhar Bharat. While listening to Professor Seth sir's keynote address, the way he described the journey of India's cardiology towards self-sufficiency was also, we also experienced the same during COVID pandemic. One fine morning, we were importing QIAGEN reagent for RNA extraction for diagnosis of COVID-19. One fine morning, USA decided not to export because they had their cases rising. And without that RNA extraction, no COVID diagnosis can take place. But that was also the time of opportunity. We realized our potential, and the kit which we were importing at 1,500 rupees got down to 50 rupees, and that was possible by all the researchers, all the scientists, and all of you here in India. We can do it as are told, and we can do it better. We did it at a lower cost. We make it affordable, available, and accessible. The road to Viksit Bharat 2047, because all of you, all the young cardiologists here, are the future architect of Viksit Bharat. And the road to Viksit Bharat has to go through Ayushman Bharat. And the road to Ayushman Bharat cannot be achieved having our heart health well. So each one of you is a co-creator and co-passenger of the journey to Ayushman Bharat. My only appeal to all of you is that when we think of high-end solutions, high-end therapeutics or interventions, let us do some research how to make it deliver at a place where there may not be a trained cardiologist available. So how do we ensure equitable and affordable cardiac care to each citizen of India, irrespective of where he or she is? And women cardiologists can do the job better. I know again, Professor Seth will not be very happy with all the male colleagues here, but we do have one added value, that is empathy. All the women physicians and all the women caregivers, they have an added value of empathy. And all of us know the importance of empathy because those who have watched the movie Munna Bhai MBBS must have seen it. डॉक्टर तो जान देते हैं, but जीना सिखाना भी जरूरी है. So congratulations to each one of you. May the spirit of women in cardiac care, which has been already ignited in this platform, grow ever and glow forever. Thank you.
Thank you so much, ma'am. For sure, your message will guide us, ma'am.
Indeed, each one sitting on the dais is an inspiration in itself for all of us to learn and look at the experience there. Great leaders emerge from knowledge, passion, and compassion, and those who embody these virtues inspire generations. With immense respect and pride, we now proceed with felicitation of our esteemed torch bearers. Yavjeevan Acharya Samman, Lifetime Preeminent Teacher and Mentor Award in recognition of a lifetime of exceptional dedication to teaching, mentorship, and the advancement of women in cardiovascular science, inspiring generation of cardiologists and contributing immensely to academic excellence. I request Sudha Chandran ma'am to kindly do the honors. The recipient is Dr. M. Jyotsna, advisor Vincas, who will be joining us virtually. Can we have her AV ready in the meantime? On behalf of Dr. Jyotsna, may I request Dr. Sujata to kindly receive the award. Can we have the AV, please?
It's the Professor Yavajivan Acharya Samman Award. Ma'am, you've just joined us. It's indeed an honor to have you as a teacher, mentor, and privilege, and an inspiration.
Requesting.
Dr. Jyotsna Madari has been our teacher, mentor, and she is the reason why Vincas is here. In 2007, she has inspired 4 women started this organization. What we enjoy today is the fruits of labors of people like Jyotsna ma'am. And we will request Jyotsna ma'am to say a few words.
Hello, dear all. It's really great to see such a nice conference in the indoor for the second time. And I know that the Vincars is grown because of few people and not because of me. Ideas many people will have it, but implementation is possible only with efficient people like all of you. I have to mention each and everyone for the upliftment of this Vincars. Kalu hi duratikramaha. We can't bypass the time. So we have to oblige to the time. Time-bound things always will click very well. so also in my life. And I'm very thankful to this organization to select me for such a efficient award. Thank you all.
Thank you so much, ma'am, and heartiest congratulations to you, and a big thank you to Sujata ma'am for receiving the award. Ladies and gentlemen, WCC26 would like to felicitate Dr. Ashok Vajpayee, a visionary and dedicated leader. His extraordinary contributions has been an inspiration to all of us. Please join me with a big round of applause as we honor Dr. Vajpayee. I request Mr. Abhilash Pillai to receive the award, and I request Mr. Shankar Lalwani, sir, to do the honors. On behalf of Dr. Vajpayee, I would like to thank the WCC26 for the award. Heartiest congratulations to both the awardees. Once again, congratulations to Sir, Dr. Jyotsna, and a big thank you to Sudha ma'am, Shankar Lalwani sir, and Abhilash sir. I now request Dr. Ramesh Dugubati, who have been a strong supporter of WinCast, to share a few words about the journey of women in cardiology. Over to you, sir.
So good evening, everyone. Great pleasure to be here. First of all, thanks to WinCars and WCC 2026, and thank you, Dr. Sarita Rao, for including me in this program. And I would like to say that actually, without a woman, there is no man, you know. And obviously, I come to India almost every month from United States just to see my mom. So, I mean, she lives in Vijayawada. The main reason that I come to US is actually to India is to find an excuse to see her. So in that process, I come and actually I want to educate everyone, and especially women in cardiology is a field that actually we probably have neglected for a long time. Women are 4 times higher risk of having heart disease than men. And we probably don't say that. We say that breast cancer is the #1 killer in women. That is not true. Heart disease is still #1 killer for women in the world. Whether you live in India or you live in the United States, doesn't matter. Actually, heart disease has to be recognized early and has to be treated much earlier on in women than actually probably in men. Smoking is affecting much more in the United States and other countries. The cigarette companies are spending a lot of money promoting smoking in women, actually. That's just because men started smoking less, I think, and they said, let's get a new group of people, which they are promoting that you can stay skinny because it causes anorexia. Smoking causes anorexia, so you don't have to gain weight. So I think that is really an unfortunate situation where we are, and we are trying to see how we can correct it. One of my passion is actually how to bring more women into medicine, to cardiology and interventional cardiology, as well as structural heart disease. So we go to our medical students and we try to understand at West Virginia University, what are the barriers for you to come into cardiology? The women actually sometimes, they're very upright and say that, your working hours are too bad. You guys come in at 6:30 in the morning and you leave at 7 o'clock in the evening. So then we went back and said that that is true, but why do we need to make our lives so difficult for women to enter into cardiology? Why can't we have a week on, week off is something which we never thought when I trained, Now, actually, people can work a week on and a week off in hospitals. So why can't we have a flexible hours? You can come in at whatever time you want, and you can actually do 8-hour shift. Nurses are doing that. Cath lab technicians are doing that without any fail in the system. The system doesn't fail. We actually are promoting that there is a risk of system failing. When COVID came, nothing actually happened to the system. We really worked very well. And I think one of the, obviously, we all thought COVID is going to really kill the system, that how we take care of patients. Acute MIs were less actually during the time of, during COVID, probably because less pollution, wearing masks, or whatever reason that we can think of, there was less risk. So I think we need to start thinking outside the box to promote women to come into cardiology, whether it is flexible hours, or we have to think about maybe a week on, week off, or whatever time, 3 days a week or 4 days a week, or creating one job can be shared by 2 women, or 1 man, 1 woman, however we think about it. It is not to say that women cannot work. I'm sure Dr. Sarita Rao goes in, and many of you go into the cath lab in the morning and come out late in the evening. But we also need to understand there are only, as I think you mentioned, there are only 500 Indian women interventional cardiologists. Why can't it be 5,000? So let's go back and try to understand from medical school students, why can't we allow them to come into interventional cardiology? We need to promote that. I think that is my passion. That's what we do. We actually have about 5 interventional cardiologists in my place. 2 of them are women, actually. So we have to make it much higher. It is only now 30%, but we want to make it actually about 50% women in interventional cardiology as well. Thank you very much for giving me this opportunity, and we all strive to be better people when we actually make women grow in our culture, in our societies. Thank you.
Thank you so much, sir, for your precious message. Ladies and gentlemen, without any further ado, let's move on to a very special moment, the book release of WCC Conference 2026, for which I'd like to request our Honorable Member of Parliament, Shankar Lalwani ji, along with Sudha Chandran ji, along with Sanghamitra Party ma'am, and Dr. Ashok Seth sir, to please grace the occasion with the book release of WCC Conference 2026.
Can we have a big round of applause for all the hard work that is put into the book?
Ladies and gentlemen, the successful release of this book would not have been possible without the tireless efforts and dedication of Dr. Jyotsna Madhuri ma'am and Dr. Sarita Rao ma'am. Their meticulous planning, commitment and attention to details has played a very vital role.
I would also like to call Mr. Vikas Khare and Sheetal ma'am, the people who supported our endeavor to write this book on stage, please. Mr. Vikas Khare and Sheetal ma'am. We do know that our endeavors are not possible without the support of others. So please, we have been supported in this endeavor by Mr. Vikas and Sheetal ma'am. We would like them to come here.
Ladies and gentlemen, once again, can we have a big round of applause?
you so much, sir.
Mr.
Thank you.
Shankar Lalwani has been called for an urgent appointment. We request the hall to give him a round of applause as he leaves, please. Requesting the distinguished guest on the dais to please sit down.
Thank you so much, everyone, for the book release of WCC Conference 2026. Ladies and gentlemen, to take this ceremony forward, now I'd like to invite Dr. Roshan Rao, sir, Senior Cardiologist and Director of Cardiology at Apollo Hospital, Indore, to share his experiences about women in cardiology and related sciences. His perspective is especially insightful given that his partner is a leading name in the field. So please.
Yeah, good evening, everybody. Dignitaries on the dais and wonderful, lovely ladies. There are 2-3 things that I would put in. That's my experience, and that is something probably everybody would agree to. So it is said that that's an adage that says that trifles makes the perfection, and so perfection also trifle, right? Now what we seek, all of us seek is completeness. So to be complete, moon takes 14 days, you know. And when we come to personalities, when we talk about being complete, women are probably the most complete personality on this earth. Do you agree with me? So whether it is work, whether it is home, I don't think that you'll find more somebody who's as complete as a woman. So my congratulations to all of you for this. Second thing, which is a journey in itself, is something like earlier it was personalities of sympathy, you know, to object of envy. You know, all the ladies who have traveled so far, and now all of you in your societies, in your places of work, you all are object of envy. So that journey that you have traveled is amazing. So with these remarks, I would not take much of your time, and I would congratulate all of you for this 18th. 18th is humongous, you know, 18th WCC conference of WinCars, and I hope that this will continue forever. And my congratulations to all the organizers, and especially Dr. Sujata, Dr. Shiba, to be here and conducting this conference. And I hope that we all meet again in Indore, probably whenever you make it possible. Thank you. Thanks a lot.
Thank you, sir. Thank you so much. Everything seems theoretically impossible until it is done, as Robert Helen wisely remarked. As we reach the midpoint of our journey at WCC26, it is my pleasure to invite Mr. Abhilash Pillai, COO, Apollo Hospital, Indore, to share his thoughts and kind words with us. Over to you, sir.
Thank you, Priya. Dignitaries on the dais and in the audience, mentors, teachers who have flown in from all over the country and the world to make it here on this evening, ladies and gentlemen, members from the media, boys and girls. I think what a day it has been, and what an evening it has been. So on behalf of the Apollo Hospital's family, I think it's indeed my privilege and honor to be here and to play our little role along with our colleague Dr. Sarita and Dr. Roshan in bringing this day and the evening together for all of you. Well, when it comes to looking at important aspects in our life, I think in India we have this usual tendency to actually go back to our roots and figure out how our ancestors looked at aspects. And when it comes to health, it's important to reflect how our ancestors viewed health. So when we look back to our text, which is over 3,000 years old, and when we look at how health was enumerated there, I think it sort of very nicely captured in a couple of phrases which says that Arogyam Param Bhagyam, which is good health, is the most important fortune for anybody to have. And Swasthyam Sarvartha Sadhanam, which is while amongst all the achievements one would aim for, the most important achievement for us in life is good health, whether it is in life, whether it is for a nation, whether it is for a family. I think good health comes to the center. And when we talk about heart amongst good health, I think we've been hearing it all day, that the burden of cardiac diseases is absolutely stunning and there's a need for something to be done about it. And what better way to summarize all our actions under this umbrella of WinCars. The second important aspect to reflect is what our Honorable Prime Minister feels that we should, as members of the healthcare fraternity, view as a lens when we look at healthcare. He talks about one earth, one health. He says that whatever you do in the healthcare space, it should not be limited to the boundaries of your country. It should be far encompassing. It should be one which will provide hope and solution not just to the members or the citizens of this nation, but to the world at large. So that's the second important ambit that you have in terms of what's the purpose. The third important aspect is that when it comes to heart, I think in our country we don't look at heart as a pumping machine alone, because we also say that heart is also the space where you have consciousness and compassion coming from. So when you combine all of this together, and then we also have Amit Sirst, Madam Sudha Chandran, who's a story about resilience. It's a story about how courage, how aspirations, how objectives can be met, and there is no words or no can't do in our dictionary. So when you combine all of the four, I think you have purpose at the forehand, followed by consciousness, compassion, and resilience. I think nothing looks impossible. And for all the young members out here in this hall, my urge to you is that on this forum, as part of this forum, we've got the who's who of cardiology here. We've got members who have done tremendous work in cardiology. How do we sort of use this opportunity to understand from them what needs to be paved, what needs to be bought in, so that whatever discussions, whatever book releases, all the important consensus which comes out of this platform, how do we put that into work, into transforming cardiac care going forward? I think that's a very, very important objective. And when you look at all of this work and put it through the prism of one earth, one health, I think what can happen is endless. We don't even need to limit our objectives into a hospital, few patients, etc. We can actually take it multifold. And I think that is the opportunity and responsibility for all of us out here. I think it's a very, very tremendous responsibility. And the lot of deliberations, a lot of discussions, a lot of presentations, a lot of work that we see through during these 2 days are only going to give us insights to better our efforts for our patient, because whatever we do at the end of the day, we keep our patients right in the center and do everything right for him, because we care and it is a responsibility. So with all of this coming together, I think it's a transformational journey. It's a proud privilege to sort of understand how this forum and how this platform is evolving and how it is sort of making a lot of difference to everybody around. And it's our proud privilege to form whatever little and play whatever little role that we have along with Dr. Sarita and Dr. Roshan, and of course everybody. In closing, I want to congratulate all the women leadership at WinCars for such an amazing platform, such a transformational platform, and it's indeed a proud privilege for all of us to be here this evening and to take the learnings forward into the day tomorrow. Thank you once again.
Thank you so much, sir. Ladies and gentlemen, before we mark the official end of this inaugural ceremony, I like to quote few lines which are the actual driving force of my life. कहते हैं, आँख में पानी रखो, होठों पे चिंगारी रखो, जिंदा रहना है तो तरकीबें बहुत सारी रखो, और मील के पत्थर से बढ़कर कुछ नहीं है मंजिलें, रास्ते आवाज देते हैं, सफर जारी रखो. with such spirit of constantly moving ahead. Concluding this ceremony once again on the behalf of Vincars, I, Dr. Sanchit Mishra,
And I, Dr. Priya Chitle,
would like to thank our esteemed guests, all the consultants, and all the delegates for gracing the occasion with your precious presence. May I now request everyone to rise for the national anthem. Attention everyone.
requesting all the delegates to be here as we have few more sessions left. We also have another session lined up in Hall B. Requesting those who want to join Hall B can go ahead and join at downstairs.
Shiba will.
Request all the delegates to kindly come and take their seats for a very important session of the day, that is the Padmavathi oration. This is the heart and corner of the scientific session. Request all the delegates to kindly take their seats.
We now move on to a very special segment of the program, the Padmavathi Oration. This prestigious oration recognizes distinguished contributions and dedication to the field, celebrating excellence, leadership, and commitment to advancing cardiovascular health. I now invite Dr. Sheba Chabra to please grace the stage and introduce Dr. Rupa Salwan. Requesting Dr. Sheba Chabra to grace the dais and introduce Dr. Rupa Salwan.
A very good evening to all of you. I would request everyone. A very good evening. Would request everyone to kindly take their chairs for the Padmavathi oration. I give the mic to Dr. Sarita, who's going to introduce the oration and then hand over.
Ladies and gentlemen, after that wonderful inauguration and inspiring words from everybody, we come to what makes WinCars special. The WinCars organization has only one oration. And for us, it goes to a woman who is special. It goes to a woman who has led. It goes to a woman who has inspired. It goes to a woman who has done tremendous work in women cardiac care. And this year's prestigious oration goes to Dr. Rupa Salwan. A round of applause for Madam. She has been one of the pioneers in cardiac care for women. She has stood as a torchbearer for us women. Many of us in our formative years have been inspired by her. And I used to hear stories about her when I was thinking of doing cardiology. Words cannot express what Padmavathi oration means to us. It means everything to this organization and to the women who are in it. And I want our director, Dr. Sheba Chabra, to introduce Madam.
Thank you so much, Dr. Sarita, for giving me this opportunity. For a moment, none other than Padmavathi oration. Who of us does not know about Padmavathi in WinCars? WinCars is Women in Cardiology and Related Sciences, and our basic motive is to talk about cardiovascular diseases in women, and research is a cornerstone. Reminiscing Dr. S.I. Padmavathi, 1970 to 2020, called as the godmother of cardiology, India's first female cardiologist. She broke the gender barriers in 1950s. She was a trailblazer of many firsts, established North India's first cardiac catheterization laboratory, founded the All India Foundation and National Heart Institute, introduced the first DM in Maulana Azad Medical College. Renowned awards like Dr. Paul Diddley Voigt at Harvard and Dr. Helen Taussig John Hopkins Awards were to her honor. She was awarded the global leadership was a Padma Bhushan and Padma Vibhushan. And today is a very special day. Because I have a woman in front of me who's going to give an oration to her name, and her name is very special. Smart women have learned that you can be kind and still be clear. You can be gracious and still say no. Softness and strengths aren't opposites. They are the grace and the grit that keep us moving forward. And I think you would all agree that aptly defines none other than Dr. Rupa Salwan. To talk of ma'am's career, Dr. Rupa Salwan sorry for a technical glitch, but I don't want to miss out on anything. Dr. Rupa Salwan is the Senior Director, Myocardial Infarction Program, Max Healthcare. She did her MBBS in 1986, MD in Medicine in 1993 from Maulana Azad Medical College and from LNJPN Hospital, New Delhi. She has received gold medal for being the best student in surgery, the best resident in clinical work in 1992. She completed her DM in cardiology from GB Pant Hospital, Delhi University, 1996. Dr. Salwan has been active in the field of interventional cardiology for the last 3 decades. She has vast experience of interventional cardiology at Escorts Heart Institute and Research Center, where she was working in capacity of consultant interventional cardiology for 7 years, and she remembers that time very fondly of having worked with Dr. Ashok Seth. She has been the founder member of cardiology team to set up Max Heart and Vascular Institute in 2004. The Max MI network has been well developed under her care in addition to standard cath lab practices. Lehman Global has recognized Max Healthcare as the Institute of Excellence for treatment of heart attacks. Dr. Salwan has special interest on cardiovascular diseases in women, structural heart diseases, acute MI interventions, complex high-risk coronary interventions, peripheral vascular disease, thrombotic disease, cardiac critical care, and she has been pioneering the TAVI programs in our country through her grit, grace, and dedication. And we are all aware of her recent research work that was on STEMI and the STEMI care protocols, the myths about which she's going to elaborate further in Padmavathi oration. We welcome you, ma'am. Kindly come and grace the oration.
I am humbled and actually quite out of words when Sarita called me and said that there was a unanimous decision to give me this oration. And I said, I'm not that old, and maybe it's, too early. And she said, no, it's time that you come up. And I'm grateful to my sisterhood who has acknowledged and given me this honor. And it's again a privilege to be speaking in front of my mentor, my guide, and now my good friend, if I may say, Dr. Seth. So I shall try. I'm not sure I can do it. I shall try. So Dr. Padmavathi is much spoken of, but if you go back, no one talks of a publication in 1962, which was on the epidemiology of cardiovascular disease in India. She did 3 groups of studies in autopsy of 200 patients with this medico-legal autopsies. She did the ESI insurance scheme, and she did hospital data. And what she concluded was that the prevalence of heart disease in Indians appears low. A disease appears in 2nd decade, peaks in 6th decade, 7th decade in women. It accounted for only 7% of medical deaths, 3% of all deaths, and at that time, 50% of deaths in the Western countries. Only 0.7% of medical admissions were from coronary artery disease, and there was a little edge of cerebrovascular disease. There was a low incidence in industrial workers. That's a journey in the last 60 years, how we have transformed from what was studied then. And also an eye-opener that we've got to carry on the work. Epidemiology did not keep pace with what she had done at that time. As a child, Denton Arthur Cooley somehow inspired me. There were so many Indians who went to the States for bypass surgery after their heart attacks. And I used to wonder that why does nobody in our country have the ability to, do treatment, and why do Indians have to go to the States? It was a very painful time when a lot of Indians went overseas for their treatment. And with that, I cleared my medical entrance. Being a doctor is an incredible privilege, and with the noblest intention of being the change you want to see, of practicing the highest standards in medical care, I started the journey of training to be a physician, to honor my calling with responsibility and be worthy of the opportunity life had given me, keeping learning as long as I can and seeking ways to improve patient outcomes, most important to bridge the gap between what is known and what is being done. The scientific method, we are all scientists at heart. It's a rigorous process of accumulating knowledge, of making observations and measurements, of seeing the patterns and validating them. It's not only knowing, but Kaizen, that's an incremental improvement that we owe ourselves and society. It serves as a check that we are not fooled by others, or more importantly, by ourselves. And there's a science, if science isn't rigorous, it's reckless. The cornerstones of scientific advancement are rigor in research and ability to reproduce biomedical research findings. As scientists, we inherently question things, including ourselves. The more personal integrity and scientific rigor are addressed during the journey, the less we question ourselves. Research is important for everyone at every stage because it emphasizes the need to analyze what we do for our patients. We always need to be curious, we need to be respectful of patient outcomes, and learning should never stop. If something doesn't work, it has to evolve over time. We combine skill, knowledge, attitude, precision, empathy, and quiet strength. We all need to find strength and grace under pressure, and most important, we have to keep science above self. Now, data is extremely important, and the days of AI, there's no way we can move ahead without generating data that's clean. The only constant of life is change. We need to learn and evolve, and methods are the means by which those goals are achieved, and we have to move beyond individual excellence to hospitals, to groups of hospitals, and to national excellence. At the threshold of cardiology in 1988, I had the privilege of working at GB Pant Hospital and organizing the national conference. At that time, CSI and surgeons had a combined meeting. In fact, the then Prime Minister, Rajiv Gandhi, had come for the meeting. There were intense debates on angioplasty and bypass, on BMV and CMV, and between GB Pant and AIMS, we were the leading institutions. We all came up with numbers, we came up with what we did. The competition was very healthy, I must say. And at that same time, in 1991, I had the privilege of attending a cardiac rehab meeting. Can you imagine, at the time when we had nothing for heart failure, at the Talkatora swimming pool stadium, we had a group of Europeans coming in and teaching swimming pool exercises which were zero gravity to get a patient from class 4 to class 2. If I have seen further than others, it is by standing upon the shoulder of giants. And my story is about that. In the cath lab is a place of purpose, creativity, and camaraderie, constant multitasking, choosing the right interventions, anticipating complications, to think clearly under pressure, to build expertise to prevent complications, and have the skills and composure to get out of trouble when needed. Complications shape us forever. We try to learn from others' mistakes, they always leave a mark. It is very important to build a collaborative environment, to value relationships, not just outcomes. Outcomes are the result of collaborative effort, not just individual talent. We've heard the story, but very briefly, cardiology evolved from masterly inactivities of the CCUs to bypass surgery, and there was a breakthrough when Grumzik started balloon angioplasty, but there were limitations. Stent, interestingly, comes from the name of a dentist who used to make molds, and the first stents were placed in 1986 in Toulouse by Jacques Puel and by Ulrich Sigbert in Switzerland. We've seen the stents, the wall stents that were very bulky, the Parma shots that came with a joint, and many Indian operators used to cut it in between and convert it into two stents. The Victor stent, which if someone was rough, could just straighten up into a wire, as did the Gyan Turco-Rubin stent. And while we had some very elegant cardiologists practicing, unfortunately a lot of people tried their hand, and that's how I know the complications of these stents. Now, when we placed stents, at that time was a very troublesome time, and we've all been in the trenches. So we were the, the so-called, dash fellows who were looking after patients, and their complications happened because of our negligence. But stents were then being deployed at low pressure with heparin and dextran, and then with anticoagulation. And when it didn't work, a cocktail of everything from urokinase, warfarin for a month was being given. Obviously, there were bleeding complications, vascular complications, and as fellows, we took it in a stride that we were responsible for all the troubles in the world. There was a time when, after all that hard work and struggle, we used to wonder that is the treatment worse than disease? However, Colombo pioneered intravascular ultrasound. It's not new, we've known it for the last 30 years. And that's what taught us how to deploy stents under high pressure, and also a bold step of using dual antiplatelet and cutting off the coumadins and the anticoagulants that were being used. You've seen an elegant display of directional atherectomy at GB Pant. Dr. Gambhir did a lot of it, as did a lot of rotas. We had the huge, bulky Rashkin umbrella device with which we closed PDAs, the coils, and of course, we were the leading center for balloon mitral valvotomy. And Dr. Kalula's leadership was good in the sense that he didn't let consultants cross tracks, and he created expertise. So the one who did BMVs was only doing BMVs, the one doing angios were only doing them. And Dr. Tyagi was the youngest consultant who joined the department, and I'm witness to that, where of all that was left was aortoarteritis, and look at where he's taken aortoarteritis. So without that, one constant factor, seeing that everybody grows and the department grows, it is very difficult to get everyone to, to the institute to really excel. And Dr. Gambhir was very generous. I mean, it's unbelievable. In 1995, I had a case report with him on unprotected, isolated left main osteal stenosis on polymorphic BT. There was a patient who was operated as pulmonary embolism, but it was a tuberculoma. It was published after I left the hospital. We were adventurous at that time. We tried to close a post-MI, inferior MI, VSD, and also an RSOV with the Rashkin umbrella device. I did a study in which we called back patients who had got steroid-eluting leads, and we programmed them to improve the battery life. But those were things that we'd worked for people, but it was not necessary. We got to publish our work. And this was the famous story of GB Pant. Eklavya ki kahani suni hai kya? So I had my learnings, I had done what I had to do, I gave my Guru Dakshina, and I moved on. And I had the privilege of moving to Escorts Heart Institute, and where I insisted, I didn't report to Dr. Trehan. I went to Dr. Seth and said, I will be hired by you, not by Dr. Trehan. And I know it was a job for him to, work around that, because that was his place, and nothing happened without Dr. Trehan's approval. And sure to say, the moment I set into Escorts, I was not allowed to put my hand on anything except the cath lab, and I was not complaining. Dr. Seth was very understanding of my need for, academic growth. And I think we made a wonderful team. That was the time apiximab was introduced. And Dr. Seth was taking on more challenging interventions. And he used to give 1 vial of apiximab. The normal dose was 3. But believe me, that kind of complicated cases we did were possible with that little touch-up of antiplatelets. And today with better drugs, we know that was the right thing to do. We saw a lot of thrombocytopenia, and then reading up about it, it's scary. I mean, you have a platelet count of 20,000, and you've done a complex intervention, and with him putting 4, 5, 6 stents was like normal, and to have a thrombocytopenia was scary, and with the surgeon breathing down your neck. In fact, Dr. Trehan's favorite expression to me when he crossed corridors was, "Ki sawan ke andhe ko sab kuch hara dikhta hai," because we were constantly getting multi-vessels into our lists, and he never liked that. So we did pseudothrombocytopenia, we understood, we studied our patients, and then there were some publications of perforations, of 2B3A use. In fact, we flooded, there was a group of us. Dr. Mathur had just come back from his carotid intervention studies, and Dr. Rathi was with us, and we just flooded the next PSI with a lot of abstracts and a lot of work that we did. At that time, even we were putting sutures, we had data on everything. So every new device was tested in the lab. And I am so grateful to Dr. Seth, because he'd say that you go read, think of it, and we discuss micro and then do the cases absolutely flawlessly. In fact, he used to come back up from NIC meetings and say, they are presenting complications, but we don't have any to show, So the simplification was, he made it look simple, but there was a lot of hard work behind that. So the epi filter, the guard wire. We used guard wire for, carotid, but also for vein graft interventions. That went out, but the export catheter is a byproduct of that. We used a nasty-looking exciser thrombectomy device. Now, the first stent infection that we had 30 years ago, there was a restlessness, and I was told to go back and study everything, and a root cause was done. And the way we draped our tables, the way the nurses prepared, the sheets that were covered, the rota wires used to flame, and we had some fellows who were very casual, and there was, in that particular case, 3 rota wires came to the floor. You know how clumsy that person was. So what we learned how to handle it. We had a very high, but while doing complexities, even low molecular weight heparin had come. You used to just give it, thoda ye bhi de do, stent thrombose nahi honge. But there was a high, we had an epidemic of pseudoaneurysms, but sure enough, we studied them. We learned to close them, and then we also stopped doing these things. There were cases where, multi-system disease would come up with the complexity. There was a patient with isolated left main where everything was done, but, she deteriorated and had multiple angioplasties, and it was aortoarthritis. So reading up about everything different, everything complete. So it was a patient that mattered. It was not just a lesion that mattered. And at the same time, the first fellowship in intervention was started, and there was a lot of satisfaction of not only doing the right things, but also sharing them with many people. Now, restenosis was the Achilles heel of stenting, and though bare metal stents were doing very well, the guidance, then the company had come up, they had really refined their stents, but restenosis was a problem, and the drug-eluting stents came up. Before the drug-eluting stents came up, we had the privilege of using the Biodivisio, which was a polymer-coated stent, and only when that kind of moved on, did the Cypher and the Taxus come, and on those days, seeing late stent apposition in Taxus and Cypher. So, Dr. Seth had a great knack of understanding the device. Cypher is a very stiff device. So a lot of stents that we used were actually undersized. I mean, I don't think we've ever used so many 2.25 stents as we did, but place it well and then use high pressure to deploy and, the stent and see that it's well opposed to the vessel. You've got to understand your device. When you've just heard his passion about atherectomies, rotablation and stuff, once you know the device, you know how to make it work, you will do always good for your patient. I was able to do a study, so when Cypher came out, it was very expensive, and we had a bunch of patients where we were doing hybrid stenting. So for big vessels, discrete lesions, we used bare metal, and for those who would afford, they were all Cyphers, and I studied 637 patients, of which, interestingly, the follow-up was possible only in 528. So patients were giving wrong addresses for sake of taxation, something that only happens in our country. But of those patients that we studied, even bare metal stents were doing very well at our hands. There was no difference in their one-year outcomes, and recurrence of angina was 3.6 in an all-Cypher group and 6.4% in a hybrid group. The first endovascular procedures, I think the first 50 of them, I do have the honor and privilege of working on them with Dr. Seth. You see, this is a very complex dissection, which is beyond the subclavian, but going behind the carotids. And for this patient, we did a carotid graft. And then, even these little things, the Medtronic device didn't have hooks to get the Cook device in. We've all lost sleep. What will happen to the spinal blood flow? What will happen to the patient? Now it's a defined science, but believe you me, 25 years ago when we were just doing these things, we all lost a lot of sleep in planning and doing these cases, and good outcomes really made it good. At that time, Endovascular Intervention Society was started because, chip intervention, other things were not so much there at that time, and that was but it didn't last long, and just as well, the endovascular work went to the vascular surgeons, and the intracranial work went to the interventional neurologists. You've all seen this photograph, and this case where it was an aortic regurgitation, where, we did a graft, the procedure went off beautifully, 45 minutes flat, it was done. But by protocol, the patient was on PCPS, and I think the sheets were very big. We had some issues a few days later, and we were not able to save the patients. But down the line, I've had my own share of TAVIs, and this patient is out of hospital, cardiac arrest, severe aortic stenosis. We did her CPR, and 2 hours later, we deployed a valve for her, and she lived for, this we did in 2018, and she died only early this year. So she had a good life. So a primary TAVI is also where I have graduated from my first training of the first TAVR. We've managed very complex heart disease, and one of my patients with, never say die attitude with a great team, even worked him up to an LVAD. You patient shifted from another organization with everything down, only an IBP, no question of impella, but a very devoted team paying attention to every small thing. We were able to get him to an LVAD. Now the next part of it is, heart disease in young has always been a topic, but a lot of it is anecdotes and we don't have very good data. And from the Global Burden of Disease, Andrew Moran had this publication where in the 2000s, it plateaued. The young heart disease that we are seeing plateaued. And so I set back to, really study what we did. And we don't have good data, but in Escorts, at least the data of PTC and bypass we had, which Dr. Seth kindly allowed me to study. And this is what we saw. So we had the data of, pure CAD. So it's not epidemiological data of ECG or pain or whatever. It is pure CAD, manifest CAD as PTCA or CABG. We had the demographics, and we found that the average age of a patient increased from 52 to 60 years, and of women from 56 to 63 years. And the number of young less than 40 dropped from 7.8% to 2.6%. I was able to collaborate at the Indira Gandhi Institute of Integrative Biology, where, Tapritesh normalized it to the population of the country. And the women were constituting only 4%, they went up to 16%, and he made similar stream plots, where with the growth of our population, actually, and the young being almost 35%, we should have been seeing far more patients. Maybe it's different, but there's a perspective to it, and which I would agree with what the global burden does. I do have permissions now with the proper IRB to complete it, and I hopefully will publish it this year. The next is in the matters of the conscience, the law of majority has no place. We've spoken of Jeffrey Hartler. Can you imagine in 1981, 45 years before today, he was doing primary angioplasty and he had wonderful results, enviable results, which even today we don't see. From that man describing it today, we struggle to give our patients the best. There was complexity in what was done, but there was a method to reproduce it, and we have the techniques of primary angioplasty have matured. The second important thing is cardiocerebral resuscitation. I had the privilege of meeting Evie Gordon at a meeting, and Poonam Malhotra would understand how we, as interns, done CPRs without interrupting because we had A lines in front of us, and the anesthetist would be whacking us to stop, and this is what it does. So when you do an interrupted CPR, you're never going to get a cardiac output from continuous chest compression. And huge respect for the gentlemen who, studied this and found the data and then got it into guidelines. And so many lives we saved has been from, giving high quality chest compressions. If you don't understand CPR, you have really no business to take a patient to the lab. Bad things do happen, hypoxic injury happens. And each of these patients who goes through something bad gives us, it's a huge lesson in humility and a responsibility to do what is known, correct, and most important, create science. And all of those behind who've been creating these protocols, immense respect for each one of them. So it was a dream when I was not able to conform to the, the corporate world that Escorts was becoming. Dr. Seth came up with this huge thing. It was a restlessness because, things weren't growing at the pace which we were growing in intervention. And there was an opportunity to create a hospital. And that was called, at that time, Max Devki Devi Heart and Vascular Institute. And it was a huge opportunity. And I was very thankful to Dr. Seth because when we got in there, I was given a free hand and I could make the protocols I wanted. And STEMI, which I'm coming to, was my dream. And there the protocols got implemented the way we wanted. It was about creating a center of excellence and creating robust STEMI processes. Believe me, I was 7 years post-DM then, and for 2.5 years, I worked more than I did in my internship with a call every third day. And not only STEMI, actually, we helped every medical emergency really come to a level where it's only gratitude I can say. Knowing is different, but I had a platform on which I could really implement what I knew, and the lives we saved were incredible, so humbling, incredible. And Max expanded and we have a good reach over the city. We all know that primary intervention is the most time-sensitive and complex therapeutic intervention. The process is measured in minutes and outcomes in terms of mortality, and it is teamwork and transition. A quality STEMI procedure, which is what we all do, starts with the efficient STEMI process. Working on the process, there is no doubt about it. And there are a lot of plan, do, study, act cycles. So in the first 3 years, we moved, we were doing about 150 primary angioplasties, and the mortalities within a year were down to a very beautiful less than 2%, which is what we were. And at that time, the management changed, the doctors changed, Attrition, 80% attrition is what we are used to. There were memorable moments. In fact, it was a British gentleman who had a primary angioplasty on his trip to India who honored me at a very elaborate function at the Guildhall in London. And England didn't have a primary angioplasty program at that time. We were struggling, but nobody was listening to our voice. We did community outreach meetings, and our primary angioplasty program grew to about 200 in a year. And from about 4% of the work, it was about 13% of the work. At the same time, and the mortalities were high, but at least the process was being implemented. And when you saw the intervention data, it was growing even in the national intervention, but very painfully, only 12% of interventions were being done as primary. 30% of recent MIs were being intervened at the convenience of the interventional cardiologist, which is not a good thing for our community. And the data is never published, but on personal request slides, the number of primary angioplasties have grown, but God knows how many are being done in the way they have to be done. I had the good fortune of associating with Lumen Global, with the topmost brains who were doing the best. Tim Henry, Ivan Rokos, Dr. Sameer Mehta led it, Batan Hue team, you name them, Cindy Grimes, Alexandra Lansky, each of them was Michael Lime, so all of them, Andreas Bombach in England, everybody who was a pioneer in what they did was there. And we presented our data, and they were very encouraging. When I showed them the mortalities, they said, it doesn't matter, the process has to be in place, ups and downs would happen. And when you are doing it in a corporate world with changing CEOs, changing financial goals, 80% attrition of nursing, it has to be acceptable, and the process has to go on. Our ICMR guest was the Devi Award recipient, and so was I at one point. And this collaboration with Lumen Global led to the GLOW. And for GLOW, I got to speak to first Dr. Salim Yusuf, Dr. Dennis Xavier, Dr. Mohanan. Each of them was so forthcoming in supporting with the data, which we shared and contributed to this outcome, which showed what all of us know, that women tend to have worse outcomes, more risk factors, higher in hospital, 6 months, and 1-year mortality. We were also able to write a document on confronting barriers to care in STEMI. Painfully, in 2023, publication from my parent institution where there was a registry where 72% patients got an intervention 71 hours after onset of chest pain, and time from admission to intervention was 8 hours. And at that point I said, enough is enough, I need to go back and get my data out. And this is what I took out. There was a time when we were very seriously doing our audits and correcting the system. The department had nothing to do with us. The quality manager, the emergency doctor, the administrator was seeing that things were being done. So went back, retrieved the data, and basically the programs are meant to leverage the certainty and manage the uncertainty of healthcare, and to create synergy in teams is what we did. And in Delhi, we have 200 cath labs. It should bother us if any STEMI is dying without an intervention in our city, in our state. So coordinating all the operators with clear pathways, one call code STEMI to activate the entire team, and regular audits. So what was wrong with the nursing, no nurse at night, no technician, and we made the door-to-balloon doctor-proof. So the biomedical team had to see that the ECG was synchronized, and the cath lab technician from the cath lab rolls gave the flowing vessel. This was not, nobody could manipulate these numbers, and they were being done properly and audited. So we did our study of 900 patients. We had the record of LAMAs. We did about, more than 95% primary, some changing over to surgery, medical therapy. We had good results. We knew our demographics. In the interest of time, I'll just go ahead. We achieved a door-to-balloon time of less than 90 minutes in more than 90% of patients consistently, but day, night, holidays, young, old, early presenters, late presenters, and it's very satisfying. I had no clue my data would look so good. But that's for the power of a system. At a time when our hospital had been sold and my program had been scrapped and the new management wanted to thrombolize, it was actually rewarding to be able to get this work, to publish it. And you wouldn't believe, when I sent this work to Jack Asia, where Norrin STEMI was published, it was turned down. And I wrote back to them, because that was the time when even Catherine had come to WinCars and to Delhi. And she was very positive, and I wrote back, you want to write about the poverty and the bad work in my country, we're a land of diversity, we embrace it. And there's enough good work happening that you need to encourage. And sure enough, the editor didn't, but I was very fortunate in Dr. Lansky, Dr. Sameer Mehta have, seen our work and they've seen us grow and they've done boot camps with us and they honored the work and they gave it a publication, which I'm very grateful to them for. Over the years, we grew as interventionists. We dropped our thrombus aspiration, we dropped the IBP. We had good mortalities, and as predictable, those who come in late did not the door to balloon is worse than a late coming in patient. It's absolutely non-pardonable to do a late door to balloon intervention when you're doing primary. Our results were quite world class. And most important, that I just highlight that self-paying dropped from 47% to 17%. So we have a population that can pay. We have a population that wants healthcare. And in the time of AI and knowledge, how can we not provide cardiologists the system? And blame comes on us. The system may be faulty. The blame comes on us. We have to take it on ourselves to improve the systems. So I'll just a few concluding slides. That sometimes the things that hold us back, it's all in our heads, and we should never give up. My idol, Dr. Kribia, his works are reminders that transformation is not only possible but within our reach. We must recognize unmet clinical needs and solve the problem. And when you decide to innovate, you have a number of people against you. But the biggest lesson is to make sure you're right, persevere, and try to jump all the obstacles and never be discouraged. I had the privilege of, Dr. Seth had mentioned Mr. Qasim. I went in 1998 and 2018 on a TAVI program. We know that specialized care improves outcomes, yet we struggle to ensure that healthcare reaches everyone. It is systems, not just expertise, models of care beyond individuals, episodic encounters, and we have to improve the way care is delivered. Nothing can really happen without blessings, and it's been a privilege to serve and His Holiness to benefit from his teachings and also be a part of some Buddhist groups. It is basically Hinduism with, and I really enjoy my learning teachings in Buddhism. And the man behind it all, my father. He would say, if I can quote because very good in Urdu, "Sakti-e bade mukhalif, sakti-e bade mukhalif, se na ghabra e ukab, ye to udti hain tujhe ucha udane ke liye." And when the last great scorer comes to write against your name, he will not ask if you won or lost, but how you played the game. Thank you so much.
I think words shall fall short to congratulate you for this amazing oration. And of course, as you said, we have to persevere. And it's not important that how you won or lost, but how you played the game is important. And we are pretty sure, Dr. Rupa, you played the game real well and you made your father proud. Of course, it's so good to have Sir here. I was about to call him. All off to you, sir, for the words from your heart.
Truly, I think it's my privilege and honor that I've sat and listened to the journey of Dr. Rupa Salma. I think she's been an amazing force. For years in interventional cardiology, I mean, when she came to me and we worked together, much of my success on my patients, much of the processes, much of what I was doing, pushing the boundaries, was because I was reliant on her, day after day after day. And that is the bonding, because I could actually say that we will do the toughest case, we'll be doing a new technique, a new technology. And I still remember I was doing it at the shoulders of Dr. Rupa Salman, because जब वो होती थी तो सब चीज़ ठीक रहता था. So that bonding grew into really a friendship, and that is why today I am now speaking to a friend, a colleague who I have major respect for. And every time that I said my memory to me, she is still my fellow, but it is totally different. Sometimes I think I may have become her fellow. But thank you, Rupa. What an amazing journey. You are one of the best that I've seen in the world.
So generous. That's so generous.
That is true. And you know it yourself that I've said this before. Thank you.
Please stay here. Thank you so much, sir, for your kind words. Please stay on the stage. I would also request Dr. Tripti Dev to kindly come up on the stage, and Dr. Sujata Vuparla to kindly come up on the stage, and along with Dr. Ashok Seth to honor Dr. Rupa Salwan for the Padmavathi oration. A big round of applause.
One of the fascinating aspects of this friendship and this camaraderie is that she can tell me anytime what's wrong with me and what I did wrong. And that's very difficult for anybody to tell me when I'm wrong. I'm right all the time.
That's exactly when I mean, you know, if you remember the quotes when I introduced you, she's the lady with grit and grace. She has all the empathy, but she also has the ability and strength to say a no. And of course, today we acknowledge her for all the work, the academics, the literature. WinCars is proud to have you. Kindly accept the Padmavathi oration from Dr. Tripti Dev, Dr. Sujata Viparla, and Dr. Ashok Seth, our senior mentors. A big round of applause. It takes a journey of lifetime to reach here. Dr. Sarita, you're being missed. Please join us. Dr. Sarita. Thank you. Thank you very much.
Thank you, all the dignitaries. We now move on to the next session, Structural Heart Session, the Transcatheter Takeover. I am pleased to welcome our esteemed chairpersons for this session, Dr. Martha Kaluzna, Dr. Shailendra Trivedi, Dr. Kavita Tyagi, and Dr. Hetan Chandrakant Shah. Joining them as a part of expert panel are Dr. Nishit Bhargav, Dr. Supreet Chopra, Dr. Shirish Agarwal, Dr. Vijay Lakshmi N, and Dr. Vatsal Kayal. To moderate the session, I would like to invite Dr. Zakia Khan on the dais, please. Over to you, Dr. Zakia Khan.
After this heartwarming session and talk of Dr. Rupa Salwan, we now move on from coronary to the structural interventions. May I now invite the first speaker, Dr. Ramesh Dagubati? No? Who's coming? Dr. Who's speaking first? Okay. So Dr. Sneha Garg. Dr. Sneha Garg, slides please.
So what an honor it is to speak after the great Padmavathi oration given by Dr. Rupa Salwan who is a pioneer in our institution, and we hope we fill in her shoes. So my topic today is cracking the code leaflet laceration and frame splitting in the VIV era. In the interest of time, I'll be focusing on the TAVR VIV. So acronyms in the leaflet modification has been bombarded since 2016. The first was Lampoon. In 16-17, Basilica came, then Batman, Elasta, BA Basilica, BA Lampoon, Open Basilica. 2022, Unicorn was done. 24, Lamacon. 25, Babycon, Cleve, and Bicon. So in structural heart, as well as in coronaries also, it all starts with a good planning. Accurate CT assessment gives us the feasibility of valve-in-valve TAVR. So first thing we see is the leaflet extension above the coronary ostium. So if the leaflet extension is not there, it is a low-risk case, but if it is there, then we proceed to the VTC measurement. If it is less than 3 mm, it is a high-risk case. If it is more than equal to 3 mm, then we proceed for the VT-STJ measurement and the leaflet-STJ mismatch. So the important values are VT-STJ of less than 1 and STJ height minus leaflet length of less than 0 is a very, very high-risk case. And if the leaflet STJ height minus leaflet length is more than 2 and VT-STJ is equal to more than 3, then it's a low-risk case. This classification is important to understand the anatomy of a VIV case. So type 1 is the safest when the aortic valve leaflet extends below the coronary ostium. In type 2, if aortic valve leaflets extend above the coronary but below the STJ, if sinuses are wide, it's a low risk case. If effaced sinuses, it's a high risk case. We have to proceed for leaflet modification. If aortic valve leaflet extends below the STJ but wide sinuses, still there is a risk of sinus sequestration. It's a moderate risk. In effaced, it's a very high risk. And in 3C with narrow STJ, it's a very, very high risk. So the first acronym is Basilica. It is bioprosthetic or native aortic scallop, intentional laceration to prevent iatrogenic coronary artery obstruction. So it is a leaflet traversal with the electrified 014 wire, and Astato XS 20 grams is most commonly used. There is laceration of leaflet. THV is deployed in annulus conventionally, and any THV can be used. So access and embolic protection is an important aspect. Dry seal sheath allows insertion of multiple catheters without a back bleed. So most commonly done is a single leaflet laceration. Radial access is used for embolic protection. Contralateral access is used for 6 French sheath basilica snare catheter and ipsilateral for a 14-16 French sheath with basilica traversal catheter and pigtail catheter for LV wire. And there is a modification if we are planning a double leaflet laceration. So the first step is positioning a snare in LVOT. Snare system positioning is very important, and snare size should be adapted to the LVOT. Place snare below aortic valve to avoid any entanglement. And TE guidance will help us also see whether we are holding to any structure or not. Then second important step is the traversal system. The traversal system positioning, a curved traversal catheter is positioned in the coronary cusp. The electrifiable guide wire inside an insulated polymer jacket is advanced through the traversal catheter to the nadir of the leaflet. AL oversized catheter for the left leaflet and multipurpose oversized catheter for the right leaflet is most commonly used. Mother and child technique is important for fine adjustment. We can also use the back end of the wire. Third step is the leaflet traversal. We shop proper wire insulation and a functioning bovie. Short energy bursts may be repeated. Check wire position after the traversal. And snaring and delivering the flying V is the fourth step. The traversal wire is snared in the LVOT and retrieved through the aortic valve in the multipurpose catheter. Anchor wire is removed and the V-shaped portion of the traversal wire is delivered to the traverse leaflet. And then finally, leaflet laceration. Pre-place a pigtail in LV if possible. Remove the slack if there is any on the catheter. Use dextrose flush, and there should be a gentle continuous pull while we are applying the electrocautery. And now, once we have done all this, still we should be very, very careful when we implant our final valve. We should attempt commissural alignment, adjust valve height to the anatomy, and pay attention to the SCJ height. Now, second variation is the BA basilica. It is balloon-assisted basilica. It is developed to counter limited splay with basilica in a redo TAVI case, particularly in TAVI with long supraannular leaflets. So it provides a more splay and it is assisted with a balloon. Next is unicorn. The acronym stands for undermining iatrogenic coronary obstruction with radiofrequency needle, traversal of leaflet with electrified 014 wire. Traditionally, Versa-Cock cross was used, and intra-leaflet dilatation and THV deployment is also intra-leaflet. A balloon expandable valve is used. So the balloon which is used to traverse should not lacerate the leaflet in a unicorn. It has a high embolic risk, and it is used when basilica splay is insufficient. And unicorn is done the intra-leaflet deployment of the valve, as you can see here in the screen. Never balloon laceration, always single leaflet, always balloon expandable valve, and hazards are leaflet can tear no matter how careful you are, and valve delivery can be difficult. One variation is Lamacon. It is leaflet laceration with balloon-mediated annihilation to prevent coronary obstruction with radiofrequency needle. Here the leaflet is lacerated. The intra-leaflet predilation is of a higher size. The balloon size is more than the leaflet size. The babycon and bicon, which recently came in 25, is bi-leaflet alteration with basilica and iatrogenic cusp obliteration using radiofrequency needle. Basilica through the right and unicorn through the left. And babycon is bilateral iatrogenic coronary obstruction, risk nullification. Dedicated devices are there, shortcut catheter and telltale system. So telltale system is a modified basilica. It is a basilica technique, but the hardware, they have sorted it out. And Trisect is an upcoming device. Unfortunately, all three are not available in India right now. This is the animation of shortcut. It is safe, controlled, predictable, goes on the 013 wire, which is 035 wire, which is already in your LV, and like that it splits the leaflet. You can see the splitting of the leaflet, RC and LC on a TEE very clearly. These are the gross differences in the aortic leaflet modification. Important is basilica can be used in native bioprosthesis, and shortcut can be used in native as well as bioprosthetic valve. TAVI is intraannular in a basilica, and shortcut rest is intra-leaflet valve deployment. And in unicorn and cleave, only BAV can be used. Now the second part, frame splitting. I'll just demonstrate a case which we did recently. A 82-year-old female post-SAVR CABG 2006 had a peri mount of 19. So it was a high patient prosthesis mismatch kind of situation, gradient 44. This is the CT planning. And the true ID of the valve was 19. So we crossed the valve with a AL1 and Termo. Then we took the valve, and I'll just switch to the, after our valve deployment, the mean gradient was of 20. So we did not achieve anything good. Then we proceeded to a Atlas Gold 20 mm balloon dilatation, and we were able to fracture the valve successfully. If you focus over here, at high pressures, you will see a splay. There is a loss of pressure in the assembly. And finally, we were able to achieve a mean gradient of 6. And there was no AR. This is the final. And my take-home message are coronary obstruction remains a catastrophic complication of valve-in-valve TAVI. Prophylactic leaflet modification saves the day. Bioprosthetic valve frame fracture frame splitting is an effective strategy to overcome PPM. And detailed pre-procedure CT is essential, and advanced techniques combined with contemporary valves expand the safety and feasibility of complex valve-in-valve TAVI, and now TAV-in-TAV also. Thank you for giving me the opportunity. Thank you, Sarita ma'am.
Thank you so much for an excellent talk. We'll have the discussion after the talks.
Thank you so much.
May I invite Preeti Gupta for her talk now?
Please call the chair. Yeah, so I would be speaking around the golden stitch tailoring mitral cooptation in the transcatheter era, and I'm really thankful for the organizers to give me this topic. We have the primary MR, which is the problem of the valves, rather than, and secondary MR, which is due to the problem in the walls of the atrium or the ventricular. So current ESC guidelines in functional MR, they have upgraded from 2A to 1 for the secondary MR with less than 50% and severe ventricular SMR. And in patients who are not having LV dysfunction, it will be 2B. Again, for primary MR, it will be 2A, and PCI followed by TIR is 2B. For atrial MR, there is a new indication in which it is given 2B. So we need to select our patients very wisely. They should be having moderate to severe MR with high risk for open heart surgery, FMR, ischemic MR, and DMR, which is flail or prolapse, history of multiple open heart surgeries. There should be no stenosis. MVA should be more than 4 centimeter, posterior leaflet length more than 6 mm, flail gap between 10 mm, and flail width between 15 mm. So exclusion is LVF less than 20% and the LVASD more than 70 mm. It is futile to do in a dilated, which is LVASD more than 70 mm. This was the Everest trial at anatomical eligibility in which the cooptation length more than 2 mm was taken, cooptation depth less than 10 mm, flail gap around 10 mm, flail width around 15 mm was taken. This is the mitral clip procedure in which we do a transseptal crossing and then we deliver the system and steering into the advanced clip into the left atrium and then leaflet grasping under the 3D transesophageal echocardiography, which is must because that will guide us in proper alignment of the clip and deployment and removal after the successful placement. There can be a risk of embolization or the single leaflet detachment, which we need to be very careful regarding that. So this is a T which is showing the septal indentation. This is very important. Our puncture should be either mid and posterior or inferior and posterior because we need a length of around 3.5 to 4 centimeters to deliver the clip and maneuver the system. So this is the handle in which we have the steerable guide handle, steerable sleeve handle, and the delivery catheter handle and the stabilizer. So I'd like to go for this animation first to show that how the mitral clip procedure is done. And this is the delivery system. We gain access from the femoral vein. We dilate it because the sheath is around 28 F, so we need to dilate and we mostly take proglides. And then we take a septal puncture in mid posterior or inferior posterior. And after delivering the SGC into the LA, we take a wire into the LA and then we rotate the system to make the trajectory and we transit the trajectory by just perpendicular. So we should be having a good orientation which is perpendicular, otherwise there can be chances of improper deployment. So we do transit the trajectory with almost 90 degree and this is done through the en face view of the T and thus we then go into the LV and then we grasp the leaflets and if the orientation is proper, we deliver the paddles and then we screw it and if this is proper, then we deploy it under the T guidance. So this is how the severe MR is reduced to almost trivial or mild MR after putting a clip. So this is the 17 years of evidence which has shown that this therapy is very beneficial and recent evidence like reshape and repair MR, they all are gathering evidence towards the good result in secondary MR, especially in which we have gathered the one guidelines. So the recent evidence is Reshape HF2, which has shown 36% reduction, and the repair MR is ongoing. We can get a reduction up to 63% reduction in the severe MR by the clip. The clips are long and wide, and we have to choose the clip according to the leaflet length and by the proper imaging, which is the T imaging. So coming to my case, which is a 64-year-old female, and she had hypertension, old MI, post-PTC, LAD, and RCA done in 2024, EF was 40%. She came in failure, and she had anti-proBNP around 2,000, and she had recurrent hospitalizations, and this patient had severe mitral regurgitation, and we took her for a single clip, and the result was beneficial for the patient. We could discharge the patient the next day, and this is how a non-invasive, almost a minimally invasive therapy in place of the open heart surgery can reduce the heart failure hospitalizations in such women. And this was a septal puncture and the SGC insertion. And we use very less of fluoro and more of TE guided in these cases. This clip alignment is done basically in the T guidance, and we can see fluoro also for the clip alignment. And these are the LVOD and the 3D and the NFAS view, they are very important. So bicommissural view and the LVOT view, they are the most important views to be taken in the T, and the NFAS view, especially in the 3D NFAS view, is very important. So this is how the severe MR is reduced after the post-deployment clip assessment, the T pre and the post insertion. And you can see we had a very significant decrease in the regurgitation. We mostly don't vanish the MR because that may result in LV dysfunction post-procedure, and the patient may have some decrease in the LV function after the procedure. So we try to leave trivial to mild MR post-procedure, and this patient went good, and she was discharged the second day. There was better, the anti-proBNP levels had fallen down. Thank you so much.
Thank you, doctor. Have a seat. Okay, okay. Next talk is actually by Dr. Veena, but she couldn't make it, so we have Dr. Chaitra to deliver this talk. Dr. Chaitra.
Thank you, everyone. Good evening, everyone. I'm Dr. Chaitra, today talking on a TAVR in a bicuspid aortic valve on behalf of Dr. Veena Nanjappa. As we all know, bicuspid aortic valve is the most common congenital valvular defect we see in general population, accounting for 0.5 to 2% of the population. 5 to 15% of Western populations who are undergoing TAVR, they have a bicuspid aortic valve, and it increased around 50% in an Asian population. The clinical paradox is that transcatheter processes, which are designed for tricuspid valves, deploying them in a bicuspid valve requires some mastering specific patient-tailored sizing and implantation techniques to avoid complications. Coming to TAVR versus SAVR in bicuspid aortic valve, guidelines says that the gold standard is SAVR in a bicuspid aortic valve, especially in low-risk younger populations. While TAVI shows excellent registry outcomes in a highly selected anatomies, Notion 2 registry proves that without strict patient selection, TAVI in low-risk bicuspid aortic valve carries significantly higher hazard ratios than surgery. There are registries on TAVR in a bicuspid aortic valve patients. Among them, the 2021-22 Partner 3 and Evolute low-risk registry showed that there is no significant difference in a 30-day 1-year mortality and stroke between bicuspid and tricuspid valve patients. And also, UN registry showed the high-risk features like calcified raphe and excessive calcium. They are the important markers of moderate or severe paravalvular regurgitation following TAVR in bicuspid valve patients. Coming to classification of the bicuspid aortic valve, as we all know, the most common classification is a CVS classification. Next, coming to Gila-Hawaii classification and Mechelina consensus. For the TAVR, we usually use the Gila-Hawaii classification where commissural orientation and CT-derived insights are used, which classified bicuspid aortic valve into bicommissural and tricommissural with or without raphe. The most common bicuspid aortic valve is a CVS classification of type 1A, where there is only one raphe is seen, and type 2, it has got a 2 raphes, and type 0 is a no raphe. The anatomical features of bicuspid aortic valve, which poses the risk for TAVR in such patients are, bicuspid aortic valve anatomy has, when it becomes severely aortic stenosis, there will be severe calcified leaflets with calcified raphe, and extra large aortic annulus and root, higher and more eccentric coronary ostial is there, and also aortopathy with a dilated ascending aorta. All these features, either together or alone, will lead to increased risk of valve stent frame underexpansion, non-circularity, paravalvular regurgitation, annular rupture, coronary obstruction and redo TAVI inaccessibility, and conduction disorders and pacemaker dependency. Pre-procedure planning requires a meticulous CT analysis, analyzing not only the annular level, but also intercommissural distance, supraannular plus 4 mm above the annulus, raphe level, and assessing the ascending aorta and sinotubular junction, and assessing the calcium extension in the LVOT. And there are different sizing methodologies for a bicuspid aortic valve sizing. Among them, Boward and the circle methods are used. Boward logistical method, it is mostly used for self-expanding valves. Among 5% oversizing relative to the annulus is sufficient. Whereas circle method is used for balloon expandable valves. Casper algorithm says that mean annulus diameter should be reduced by 0.5 to 1.5 mm depending on the total calcium volume and raphe length. And the shade rule in TAVI in bicuspid aortic valve is a plant it high. Deep implants in bicuspid aortic valve exponentially increases supraskirt PVR and pacemaker risk. For balloon expandable valve, the target is to place a 90-10 or 100-0 depth, whereas self-expanding valve, it is 1 to 3 mm implant depth below the annulus. Bauer logic registry has shown 3 morphological features of bicuspid aortic valve configuration, of which tubular, flared, and a tapered configuration. Most common are the tubular and the flared, for which the annular size will be standard annular sizing. For a tapered configuration, there should be a down size using ICD sizing to prevent severe underexpansion. Yoon et al. Registry has shown that presence of a calcium in the cusp increases the mortality by 19%, raphe calcium by 13%. Both presence in the calcium, raphe and leaflet calcium increases the mortality by altogether 26%. Coming to one of our case, we had a 69-year-old female with a severe symptomatic AS presented with a recurrent ADHF. This is her echo showing a severe concentric LVH with moderate LV systolic dysfunction with severe aortic valve stenosis. We could see bicuspid aortic valve with calcified leaflets with a aortic valve gradient of 88 by 52 mm of mercury. Her CT analysis showed severely calcified bicuspid aortic valve of type 1A of serious classification. Annular diameter was 23.8. Based on the intercommissural distance at the level of +4 and +8, our case belonged to a flaring type of morphological type of Bauer's logical classification. Our patient had a good coronary heights. Our CT showed calcification which is present in the raphe and also in the LVOT. LVOT aortic angle was 45 degree. Here we could see fused cuspal length being around 18.3 mm and NCC length of 16 mm. The calcium volume in all the cusps are more than 300, which suggests the increased risk of complications in such patients. And peripheries were adequate for the procedure. After analyzing CT and pre-procedural analysis, we are dealing with a patient with a bicuspid aortic valve of type 1A severus classification with moderate LV of around 18.3 mm and favorable iliacs. We had a choice between the balloon expandable and also self-expandable valve based on the advantage and disadvantages, whereas balloon expandable valve, there is a more risk of annular rupture and increased aortic root injury with increased requirement of pacemaker. And self-expandable valve, there was a more increased risk of under-expansion with increased risk of paravalvular leak and also difficulty in coronary access. We decided to go ahead with the balloon expandable MI valve of size 23 mm. Under fluoro guidance and fluoro and angiography guidance, punctured bilateral femoral artery and vein, and right side femoral artery was taken as the primary axis. And the left femoral artery taken for a pigtail and also left femoral vein for the pacemaker. Coronary angiogram done, which showed a normal coronary vessels without any significant lesions. Aortic root angiogram, you can see without any angio, under fluoro itself there is a densely calcified aortic valve, so ours was coming under a high risk feature. Aortic valve was crossed using a 6F AL1 straight tipped termo, and pre-dilatation was done using a 20 mm mammoth balloon. We could note the shift of the calcified leaflet across the left coronary ostium. In order to prevent, because of the shifting of the leaflet calcium towards the coronary ostium, we decided to protect the coronary, and the valve was deployed across the aortic valve. Following which, we could notice the under expansion of the valve, and also there is some overcrowding of the studs. So we decided to do a post-dilatation. After post-dilatation, there was an ostial LMCA spasm or narrowing was seen. And different views were taken in order to confirm the significant obstruction of the coronary, and extreme RAO cranial view was also taken, but there it was not suggesting of significant. Because of the different views were showing a different in the ostial LM, we decided to go ahead with the imaging, and IVUS was done, which showed no significant obstruction at the LM ostium. Intraprocedural IVUS helped us to decide on whether to do a stenting or not to do a stenting. There is a study in a JAC intervention which showed IVUS led to stenting deferral in 63% of the vessels deemed at a high risk of coronary artery obstruction. The learning points in our case was bicuspid anatomy can be challenging, and proper procedural planning is a key. And a few questions that throws in our case was, should IVUS be used to determine the necessity for stenting, or is angiography alone sufficient? When should we plan for a pacemaker post-hour? How many days should we wait for a rhythm to stabilize? As our patient had an intraprocedural LBVB also. Outline for bicuspid aortic stenosis therapy selection is that fundamentals still apply. Surgery is the gold standard in bicuspid aortic valve with aortic stenosis with dilated ascending aortic root of more than 45 mm with annular dimensions outside the TAVR range and extreme calcification, extreme AV complex shape deformity, and also coronary anomaly and pure AR. Whereas transcatheter is still advisable in high or prohibitive surgical risk patients and absence of a TAVR contraindications. Thank you.
Thank you for the excellent talk. Have a seat. Yeah, please. May I now invite Dr. Monica to present her case?
Good evening, all the dignitaries present here from across the globe. I am Dr. Monica, Associate Professor in Cardiology at KMC Manipal, Mahe, Karnataka. So today, thank you, Vincars, thank you, Sarita Madam, for giving me an opportunity to give a talk in front of such a wonderful crowd and stalwarts in cardiology. With this, I would like to start my talk. One second. This is not a slideshow. This one, yes. This slide you connect? Okay, correct. I'll do that. Okay. So today we are going to discuss about the planning to success for TMVR. How do we plan the procedure? How do we go ahead and have a successful TMVR outcomes in any of our patients? My disclosures and disclaimer. I have no disclosures, but I have a disclaimer. My husband is a cardiac surgeon. So let's start. The first transcatheter mitral valve replacement was done in human in 2009 via transapical approach. The first valve in MAC was done in 2013 via transcatheter apical approach by none other than our own Vinny Bapat sir. Then came the largest study of transapical TMVR, including 50 patients, which was also done by Vinny Bapat sir. And then there was a rapid growth in TMVR technology that has led to use this technology for treating the degenerated bioprosthetic surgical valves and the failed mitral repairs. 90% of the TMVR and TAVR are done outside the cath lab, and only 10% of the procedure is what we execute inside the cath lab. That means planning is the most important aspect of any structural heart transcatheter intervention. With this, I would like to start. It's very important for us to understand the mitral anatomy, which is a complex anatomy, as if any disruption of mitral ventricular geometry can lead to maladaptive remodeling of LV and left ventricular dysfunction and heart failure in patients with TMVR, even after successful procedure. Now, today, TMVR we can do in degenerative mitral valve surgical bioprosthesis, dysfunction of mitral valve ring with severe MR, and mitral annular calcification. However, the outcomes in mitral annular calcification are not encouraging. But science is still growing, and now we have the transcatheter mitral valve for native valve replacement in the valve which has just come up, which is Alta valve. It is a supraannular valve which can be used even in native valves. So we start with patient selection. Patient selection is extremely important to know the suitability and the safety for the procedure. We must know the history, symptoms, surgical risk, heart evaluation, detailed evaluation of the patient with transthoracic and transesophageal echo, and a CT with mitral focused 1 mm cuts. After we have confirmed the suitability and the safety for the patient, then only we plan for the procedure. So how do we select the patient? We do echo evaluation, meticulous echo evaluation, ruling out infective endocarditis, abscess, IE, and also the suitability of interatrial septum for septal puncture. Now, CT evaluation plays a crucial place in planning TMVR, because in CT, we mainly are focused on annular sizing, assessment of anatomy, and whether neo-LVOT obstruction is likely to happen. So neo-LVOT area is an extremely important parameter which we determine from CT analysis. So assessment of risk of LVOT obstruction by calculating neo-LVOT area on CT is very important while planning TMVR and the procedure if LEMPUN is required. Because if neo-LVOT area is less than 1.7 centimeters square, we must plan
for either surgery or we can plan for lampoon. The success of the procedure is definitely depends on correct identification of surgical bioprosthesis, choosing the correct size of transcatheter heart valve, and its subsequent delivery. There are, however, multiple surgical heart valves and rings, which some of them are suitable, some of them are not suitable for TMVR. So it's important for us to know that every valve is different, every ring is different, and every patient is different. So every patient should be evaluated meticulously with the help of surgeon. Never, never forget our surgeon friends when you are planning TMVR. So we have some stented valves and non-stented valves. Why it is important to know? In stented valves, we can see the saving ring, and it is easier for us to determine the adequate position for the valve deployment. However, in stentless valve, there is no saving ring seen. So the deployment becomes difficult. We must be very careful when we are deploying the valves in stentless prosthesis. So these are the transcatheter heart valves available right now. And the ideal position for transcatheter heart valve for TMVR should be inside the surgical bioprosthesis. So ideally, it should be 4 mm below the saving ring. And it differs valve to valve. We have to analyze the CT for every patient and then decide. Why it is important to know the level of saving ring? It should, because our valve deployment should not be very low as seen in this picture, and it should not be very high as seen in this picture, because it prompts for high chances of embolization of the valve. Now, rings are also important. We have to know our rings. Some of the rings we can do TMVR, some of the rings we cannot do TMVR because it may deform the valve. With this, Vinny Bapat sir has done a lot of work in TMVR as well as in tower, and with his vast experience, he has come up with the app called Mitral VIV Mitral. So VIV Mitral is the one-stop solution for planning any TMVR for any cardiologist across the globe. So what do we have to do? We have to download the app. Once you download the app, you open valves, then you select which surgical bioprosthesis is there. The surgical bioprosthesis details will come, how it looks in fluoro, and then it will come, the size will come, and then they will tell you how it should be done, and which valve should be used, which is suitable, which is not suitable, and what are the possible complications, along with the videos which are given by different operators, step by step, how do you do TMVR. Then you go ahead, this is my checklist before we go ahead for the procedure, and proceed with the procedure in general anesthesia, CTVS backup, TE probe in place, and excellent team coordination. So this is the case, 72 years old male with status post bioprosthetic valve 10 years back and tricuspid annuloplasty for RHD. Now he has come with dyspnea on exertion class 3 to 4. Now this is severe MR. We can see the flail bioprosthetic leaflets and severe MR, and we went ahead and planned TMVR. So CT analysis showed LVOT was roomy. We went ahead and did a perfect posterior inferior puncture. This is the septal puncture video. Yeah, that's a perfect puncture. You can see echocardiographic as well as fluoroscopically. And we went ahead and put the edgeless sheath, put our wire across the LV, and then exchange it over short curve safari wire. Then we advance the valve, and the valve is deployed. And every transcatheter valve, we have deployment points. Like in this, we have to see whether we are aligned. My valve was the mosaic valve, which is the toughest valve in which you will be doing TMVR. Mosaic and Henac valves are not very much suitable for TMVRs, but however, this patient needed it, so we did it. And this is the final result. So my take-home message would be, TMVR is a safe and effective therapy in failed surgical bioprocesses in patients with high risk for surgery. There is significant improvement in NYHA functional class after TMVR in all patients, in VIV particularly, not in MAC. It requires pre-procedure meticulous imaging and planning, and for excellent post-procedure outcomes. And for everyone, Mitral VIV app is the one-stop solution for TMVR. With this, I would like to see, these are all the stalwarts of structural heart interventions and cardiology across the globe. It includes lots and lots and lots of WinCar members and Dugapati sir and entire world along with Vinny Bapat sir. I told him we'll always have your photograph if you are there in my talk. So these are the structural heart stalwarts in one frame. And thank you. Every cath lab success is a teamwork, and that's my team. And this was my first TMVR. I did it with all your blessings. Thank you so much.
Thank
Good
you,
evening,
Monica.
Dr. Monica.
You can have a seat.
Dr. Monica, I'm Dr. Surpreet Chopra here.
Yeah,
I'm a
surgeon
cardiothoracic
friend.
surgeon. And beautiful explanation of the whole procedure, and I just loved your presentation. However, I have a small question to ask, and that is that TMVR, instead of that, we know that in degenerative mitral valve disease, surgical intervention is gold standard. However, I would like to ask you, what do you think is your threshold while considering a patient for TMVR, especially in younger patients and in intermediate risk patients? What do you think your threshold is?
Of the patient is 1. If age is above 65 years or 70 years, patients are most of the times unwilling to go for another redo, another surgery. Redo surgery per se itself is a task, and I know it's very, very difficult for a surgeon to access. So TMVR comes in picture when the surgical risk is high. If the surgical risk is low, yes, I would like to send my patient for surgery, but most of the times when we are doing valve in valve or valve in ring, they won't be really, really ready to go again under the knife second time, especially because of the age. Thank you.
Thank you, Monica, for that excellent talk. You can have a seat. May I now invite Dr. Dagubati, who was kind enough to allow ladies to speak first. Dr. Dagubati, for your keynote lecture. We are all awaiting this special lecture.
Thank you once again. Great pleasure to be here in the midst of great women, powerful women, I should say. I really appreciate involving men in Women Cardiology Conference. Dr. Sujata and Dr. Sarita Rao, Dr. Josna ma'am, and several other cardiology chairs and chiefs of departments in their own hospitals. So my talk, I think while it is being loaded, I'll just say that earlier in my mention, I didn't talk about my wife, actually. My wife is, she was offered cardiology. She said, absolutely not. She loves oncology. She actually, there's a lecture that is named after her. She's so dedicated, so successful. If you see me, that means actually she's 4 times much more successful than I am. And so please, actually, that I'm able to travel is because of her, that she's actually at home. Men only do one job, that's it, right? Only one job. That too, probably they don't do a good job. So men only do one job, which is actually whether they are at home, that's, or in the hospital, that's it, one job. Whereas a woman actually is a successful mom, successful wife, successful physician wherever they are working, and actually has to, so in at least 4 different ways that they are very successful women. So I think they are very hard jobs. Can you try to load my presentation? He said he's going to bring my presentation from the, or I can put my laptop. Can you? Yeah. Yeah, no audio, no audio. No audio, but yeah. Okay. Yeah, so I'm so sorry. I didn't have any jet lag, but actually I forgot my laptop on the plane today, and they were able to get it thanks to Dr. Sarita Rao, so many helpers that you have. So let me start actually the early TAVI revolution, and are we going to redefine asymptomatic aortic stenosis as the talk that has been given to me. I'm very privileged to talk about this because I think this is going to change how we manage our patients in the future, and it is going to be truly a revolution. So let me start off with one patient, okay? See, a 79-year-old farmer. West Virginia is a rural part of United States. It's very difficult. You should visit. Sometimes it is like really bad roads. And so when it snows, it is really, we went to minus 20 degrees Celsius just a month ago. And snow is never removed. So it's all, but lot of farms and the coal. So farmer, 79-year-old, he has 25-acre farm. He does everything on his farm. Hypertension, hyperlipidemia, coronary artery disease, non-obstructive, NYHA class 1 dyspnea on exertion, severe aortic stenosis with an ejection fraction of 40%. As you can see, it is severe by gradients and the valve area. And STS risk score is 5.4, and he has some calcification which was really felt to be too high and called porcelain aorta. And was seen by 2 cardiac surgeons. They felt, because of porcelain aorta, maybe Dr. Chopra would have done this case without even blinking an eye. Dr. Surpreet, she's not paying attention, but inoperable by 2 surgeons in the United States, okay? Whereas in India, I'm sure they would have tackled this without any difficulty. So this is an off-label use of TAVR because of the valve annular area is much larger, 814. And as you can see, it is bicuspid, very heavily calcified, bulky leaflets. And so in this patient, balloon aortic valvuloplasty was done, and TAVR was done as well, and successfully done with a balloon expandable valve, seated valve, no significant AI. And as you can see, the TE post-implant shows very good placement of the valve. And these are the gradients, okay? So, and I asked you to, gave you this scenario because for us to understand actually what are the current guidelines in asymptomatic severe aortic stenosis. So how many of you, before I show this slide, how many of you would have treated this patient with the class 1 dyspnea on exertion? Please, by show of your hands, raise your hands whether you would have treated or not. A lecture, and somebody asked a question to Catherine Otto and said, how aortic stenosis? And she said the valve area less than 0.3, probably I would not. Anyone above 0.3, she would put them on a treadmill stress test. I'm like, okay, that actually probably is a little bit more. I'm worried about anyone less than 0.6, but I think that's all numbers we make up in our own mind. I don't think she has any evidence as well, but anyone with severe aortic stenosis can be placed on a stress test. The answer is yes, okay? So we should do that, and if there is a fall in blood pressure during stress test or a very severe aortic progression of velocity of more than 0.3 meters per second per year, or increase in BNP levels, all those are 2A with B evidence of B in both the American and European guidelines. Why are we looking at patients? So this is a nice paper by Philippe Genero looking at actually about 1 million patients, 1.6 million echoes done over 4 years, and looking at these patients and what happened to them. Patients who are classified as moderate to severe or severe aortic stenosis had a mortality about 45%. Okay? Moderate to severe or severe had a mortality about 45%. Even people who had mild aortic stenosis had a mortality about 25% at the end of 4 years. So just think about it. Whom you thought 4 years ago was nothing to be done and go home, okay? But why is this important about staging? Staging of cardiac damage also actually has been shown that it increases mortality. In people who have stage 1, there is actually about 8.5% all-cause death in symptomatic severe aortic stenosis, and asymptomatic severe aortic stenosis about 5.7% mortality in asymptomatic moderate or severe aortic stenosis. Moderate or severe aortic. If they are symptomatic and asymptomatic and have stage 4, meaning right atrial pressure is elevated, mortality goes to 18.6% at the end of 1 year. So trials are likely expanding indications for AVR. Let's look at a couple of trials now in the next few slides. AVATAR is early SAVR associated with reduced all-cause damage, all-cause death, MI or stroke or heart failure hospitalizations with an STS risk score of 1.7%. Early TAVR, that is one of the really changing guidelines in the future. We'll talk about that. EVOLVED is a negative trial. Recovery again is a surgical AVR. It is a positive trial. Time is over, I think. So let's look at this recovery trial, which is an early surgery versus conservative in a small group of patients, actually that conservative care increases mortality. Death from any cause increases with conservative management in this recovery trial versus in asymptomatic severe aortic stenosis patients. They did not undergo, all of them did not undergo stress testing, and the mean gradient is actually 63 on the average in these patients. And so only 70 patients in each arm, very high mortality with conservative therapy. Let's look at another smaller trial. AVATAR trial looked at about 150 total patients. Also conservative versus early surgery. Early surgery actually had lower incidence of MACE, about 20% as compared to 40% with conservative management at the end of 4 years. EVOLVE trial, remember I talked to you about cardiac damage. These patients, it is a negative study to treat them with SAVR in patients who have myocardial fibrosis already. So this is a trial that is negative, that we know. We thought that we might do some benefit with MRI, evaluation of MRI. MRI shows myocardial fibrosis. That means we have already probably missed the boat. So early intervention and early imaging is probably what would have changed that the patients in this study. So now let's talk about early TAVR, which is much larger, about 900 patient trial, looking at actually death, stroke or unplanned hospitalization for cardiovascular causes with clinical surveillance. About 51% met the endpoint, whereas only 35% met the endpoint with the TAVR. So offering TAVR in purely asymptomatic severe aortic stenosis. How many of them underwent stress tests? 93% of these patients underwent stress testing, asymptomatic. Okay. Death from any cause did not make any difference, and even up to 5 years, the average age of follow-up was about 3.8 years. But stroke, surprisingly, we think that TAVR should not be offered because we can cause a stroke, but in clinical surveillance, they had more incidence of strokes than actually TAVR arm itself. And unplanned hospitalization also is much higher with clinical surveillance. And when should we treat these patients? I think keep an eye on ejection fraction, keep an eye on the BNP and symptoms that are gradually progressing. You might actually pay more close attention to those people. And definitely progression of disease is much higher in people over 75 years of age. I saw, the oldest I've treated is 98, and she actually just completed her 100th year. She was a nurse in our hospital. And so these patients are really we have to make them understand this is a disease of the elderly. Only 75 years and above probably will definitely get severe senile degenerative aortic stenosis in the United States, but probably 10 years younger in India, as I was being told. Okay. So, but offering TAVR in younger people, is it going to cause harm in asymptomatic severe aortic stenosis patients? We have data up to 5 to 7 years now. So bioprosthetic valve failures is no different between surgery and TAVR in PARTNER 3, the balloon expandable valve. There is no difference at 7 years. In Medtronic recently published data just about 2 weeks ago, about 5 to 7 years, we are seeing a little bit of failure of the valve, but also surgery doubled up as well. So both of them are creeping up a little bit in bioprosthetic valve failure. So we have to have more data. Now we are doing an Envision trial, which is going to follow for 10 years with the Abbott valve, Navitor valve. Okay. So what are the trends in utilization of aortic valve replacement for severe aortic stenosis? SAVR is coming down and TAVR is going up. If we did not have COVID, we did about 82,000 TAVRs in the United States in 2020. But if we didn't have COVID, it would probably in 22, it would have gone to 120,000 TAVRs. And this is probably what we are going now towards that in our institutions as well. So the mortality burden for untreated aortic stenosis is much higher. As I said, only 60% are being offered. 45% mortality rate over 4 years without AVR. And do we change the guidelines? This is my last slide. Yes, we don't identify or treat patients early enough. Very severe aortic stenosis, we should not wait, and we should actually put them at some other assessment, whether it is right heart cath or left heart cath, and looking at their EDP and right atrial pressures. LVEF less than 50%, don't wait. At some age, don't wait. Is that 70, 75, 80? In the United States, it's probably going to settle at 70. I think in India, probably it should be around 65 in my opinion. Some people say 60, but probably 65. And valve durability over 10 years matters. Do we have evidence for that yet? No. So wait for some more data before we offer TAVR in asymptomatic severe aortic stenosis, especially in younger people. In older people, up to 7 years life expectancy, I think it is okay. Good surgery in excellent hands. I think in India there are people who have done 2,000 AVRs in a year. I think those people probably, those surgeons are really very talented, and everywhere they can do any type of surgery. I think it is all right to do surgery. We must consider lifetime management in these patients. Whether the valve is going to last longer or the patient is going to last longer is a question that we always try to decide. And EASY-AS trial is a new trial that is going to trial 2,844 patients, and whether SAVR or TAVR or medical therapy, and the results will come out in 2031. Thank you very much.
Thank you so much for that excellent talk. I'll only allow one question in interest of time. Only one question from any of the panelists or audience.
Just one thing, sir. You mentioned about LVEF and TAVR. Actually, even if LV does not improve, whether if the scar burden is high, if we do TAVR, patient will improve symptomatically, and his functional class will definitely improve. That is what I thought I should add.
Yeah.
Thank you so much for a wonderful talk. We learned a lot.
No, thank you very much. It's true that actually, my point is that do not wait for the LVEF to go down. Patients will do better even if it is paradoxical low-flow, low-gradient aortic stenosis or a true low-flow, low-gradient aortic stenosis who do not have myocardial reserve. They will still do better. There's no question about it in people who are symptomatic. In asymptomatic severe aortic stenosis, waiting for that EF to go down should not be done. We should be aggressive in trying to assess the patients much better. Your mic is not working.
Okay, I think I'm hearable. I would like only to thank for this very nice all the lectures, but I think what we can summarize also at the end, having the example like aortic stenosis, that we must for sure move from the disease of the valve to the disease of the heart. So aortic stenotic heart disease, I think, is the key issue here. And I think we face with the same problem with, for example, tricuspid regurgitation, that our decisions are a little bit too late to really serve the patient the best option.
I completely agree with that.
Sir, it was an excellent talk, and always we learn from your talk. As it's a female conference, the female gender do better in tower populations. So what is your take-home message?
Absolutely. The two older patients that I've done, 94 and 98, they were both women. So the women definitely are much better in tolerating this disease. Thank you.
Thank you, sir. Ramesh, sir. Sorry, I have got one question. While doing the procedure of TAVR, new onset LBBB, if it is there, so how long we can wait for a pacemaker without any other rhythm abnormalities, patient being asymptomatic?
Yeah, this is a routine problem for us. We send them home for 2 weeks with MCOT, we call, like a Holter MCOT monitor for 2 weeks, and if they have any problems, we'll do a pacemaker before that, otherwise no pacemaker.
So with the LBBB, patient can stay like without doing anything?
Asymptomatic LBBB, discharge home the next day with the 2 weeks monitoring, and that's it. Yeah.
Because our patient had an intra-procedural LBBB, but he was asymptomatic,
Yes.
but afterwards he developed a pacemaker dependent that symptom, so we put a pacemaker in it.
So intra-procedurally, even if they have complete heart block, we still actually do not temporary pacemaker and try to wean it off next day, and if they still have left bundle, we will discharge them home for 2 weeks monitoring. Yeah. Thank you.
Thank you so much. We conclude this session. Dr. Daggubati is here. Dr. Daggubati, with you. We can interact with him later.
All the audience with Daggubati sir, I would like to tell, because sir said his wife is more than him. So I would like to say, there is nothing in cardiology a woman cannot do because she is a female. Everything is possible. I can do everything in cardiology. There is nothing in cardiology which I cannot do because I am a female.
That is probably better with them.
Thank you.
I request all the dignitaries to kindly collect their mementos from the right side of the stage. Thank you. Moving forward to the last and final session for the day, CTO session, Crossing the Void. I am pleased to welcome our esteemed chairpersons for this session, Dr. Sujata, Dr. Idris Khan, Dr. G. Selvarani, Dr. J. Cecily Mary Majella, Dr. Tripti Deb. Joining them as a part of expert panel are Dr. V.K. Singh, Dr. Ritu Bhatia, Dr. A.D. Bhatnagar, Dr. Vaibhav Shukla, and Dr. Gaurav Singh. To moderate the session, I would like to invite Dr. Alkesh Jain to be present on the dais.
Good evening, everyone. Since we are running short of time, we'll start with our first speaker, Dr. Saiko Takahashi.
Yes.
She'll be speaking on the spotlight lecture, When Not to Open a CTO, the Art of Saying No.
Yes, I need it because this on my side, I don't have, so need to return my side. Have, at this, This one? Yes. Okay. Yes, yes, yes. So may I start? Okay. Okay, so I'm very happy to be back in India again. So I'm from Japan. Japan is a country of CTO lovers. But Dr. Sarita gave me a very tough topic. Why not to open the CTO, the art of saying no? So today I would like to share my thoughts with you. So in field of CTO in Japan, there are many legends. Some of you may know them. So Dr. Mitsudo and Dr. Tamai sadly have passed away, but Dr. Kato, Dr. Suzuki, Dr. Saito, they are still working actively. And I think the evolution of CTO PCI is the story of guide wire innovation. So let me briefly introduce the history of CTO in Japan. So in 1991, the world's first live transmission for CTO was performed in Osaka. So around that time, Dr. Kato, Suzuki, and Tamai asked the Asahi Intech to collaborate to develop the dedicated CTO wire. And after that, Miracle Wire was born, and it was used for the live transmission from Italy to New York. And after that, Dr. Mitsudo made Conquest Wire. And that wire helps to do the parallel wire technique easier. And in 2001, retrograde approach was introduced during the live transmission at CCT in Kobe. And next year, CTO Summit was held in New York, and these 5 Japanese doctors were invited to do the PCI of the CTO region. And after that, card technique and reverse card technique were developed with new devices with turners and field wires, or Corsair. And in 2007, finally, EuroCTO was established, and after that, CTO, PCI for the CTO rapidly expanded across the world. So the success rate shown in black represent a result from expert CTO operators, which is consistently higher than 80%. But the blue result represent population-based registries, and in the real world practice, a large population of CTO PCIs is showing the lower success rate. So CTO PCI is not a quick and easy procedure. This is my favorite paper about JCT score. This model predicted the probability of successful guide wire crossing within 30 minutes. And it has 5 factors: entry shape, calcification, bending, and occlusion length, and retry lesion. So the score is 0. The success rate of crossing the wire within 30 minutes is 90%. But the score is more than 3, the success rate will be less than 10%. So I will share the case, and the patient was 50-year-old male with a heart failure, and she was done, and his left circumference, the branch was totally occluded. We see the collaterals from left coronary arteries, and there's a moderate stenosis in proximal LAD, and the RCA was totally occluded. And his JCT score was 4. So we thought antegrade approach seemed to be difficult, we started to attempt a retrograde approach via septal collateral. So we used 5 guide wires, but retrograde wire failed to cross the occlusion site. So we switched to the antegrade approach and used 4 guide wires. But anyway, we couldn't cross the occlusion site. And reverse cut technique was done, but it was not successful. So we finished this procedure as a failure. So after 12 years later, CT was performed for this patient. The patient remained asymptomatic with no hospital admissions. Coronary anatomies remained the same and the optimal medical therapy. The randomized trial by Dr. Park and colleagues in Korea compared outcomes between CTO with PCI and CTO with a PCI. The study showed no significant difference in prognosis between the 2 groups. So I do not know these are right answers. However, key considerations are procedural risk and success rate. When the risk is high and low success rate is anticipated, we should ask, does this CTO really need to be treated today? Their CTOs should not be attempted today. But important thing is for our future CTO procedure, it depends on the expanding training, proctorship, and education, and increasing expert operators and specialized centers. But anyway, many interventionists may resonate with the famous quote, why do you want to climb Mount Everest? Because it's there. The progress of CTO PCI has been driven by a spirit of continuous challenging and passion. Thank you for your attention.
Thank you, Dr. Takashi. It was a very nice presentation. Just one question. After a failed attempt for CTO, what do you recommend for the next, at least how much duration, after how much duration we should reattempt?
For this case?
For any failed CTO PCI.
Next attempt? You mean next attempt? So usually, if the both antegrade and retrograde approach are failed, I think maybe we should consider to send patient to CABG because I think CTO, as you know, CTO procedure also costs a lot because we use so many guide wires, and usually I think some doctors will do, but usually we will send the CABG if they need.
Any more questions? Okay. So we'll move to next speaker, Dr. V. Suryaprakash Rao, for planning step-by-step CTO strategy thinking.
First of all, I congratulate Dr. Sarita Rao and team for the excellent conduction of this program. Late evening, I accept, but never do the CTO PCA in the very late evening like this. The first thing is you should plan your CTO PCA whatever early hours of your work. That's very important because it is totally a different ball game. And you need a lot of hardware, you need a lot of patience, patient needs a lot of money also. Yes, procedure preparation, team approach, and equipment. All three are important. Never try to compromise because you will end up in failure. Yes, the passion is there. It starts with passion, but you will learn after some time it is not passion. It's a skill with a lot of outcomes, good and bad outcomes. You will learn a lot, and then the passion becomes learning, big learning, and learn and continue to learn new skills. And you should learn how to manage complications. And you should review your failures, success starts very slowly, build very steadily. Don't overhype. Yes, who should undergo? Symptomatic patient definitely. As he said, the doctor from Japan, from whom the risk of procedure override by the benefit. And always takes into the personal complication rate. How many cases we have done? I am doing this job for last 20 years. So I get many referrals from different parts of the country. Still, I read them number of times. I take a lot of time to give my decision. Your success rate, specific risks of approach, how badly impaired the patient is, general condition of the patient, very important, comorbid issues. And be mindful of your team who is supporting you. It is not individual attempt doing a CTO PCA of complex nature. Institution strengths, how is the institution supporting you, and the protocols and training. And you should know yourself, your equipment, and sometimes you have to live to fight another day. Don't go into ego problems. And definitely you need a lot of friends, resources, and have a plan. There are many algorithms are there, AP-CTO algorithm. There is another algorithm of CTO Global. I am part of this algorithm. I contributed for this. In this, the change is coming many, but important thing is, because I used to do a lot of retrograde procedures, but my retrograde number has come down because a lot of anti-grade approaches have come, the robust techniques, a lot of hardware has come, a lot of new wires have come. So first attempt should be, if possible, unless there is a JSCTO score very high, a failed case, primary indication for retrograde, better to do anti-grade. And a dual injection is compulsory. Even many methods have come. Now the trend is IVAS guided punches. Even antigrade and retrograde also, the IVAS usage is more. Another important thing is, particularly Europeans do a lot of ADR techniques. In India, ADR techniques did not become that popular. We thought we'll do a lot of stingray cases, but the cases has come down because we are able to get success with the other technology and the hardware. And the old parallel wire still remains a good technique. These are the conclusions what I can tell. I need not tell about the score. And CT scan, yes, I do CT advice for IJCTO score, and people having a long CTOs with calcium and failed cases particularly. What is the reason? Because the other operator also must be experienced why he failed. There must be a good reason. That's why I do CT for particularly osteal stump occlusions, where you have to manage. Like dual injection is a must. You can see the length of the lesion, how much the calcium is there, how are the collaterals are there, ambiguous cap. All this information comes in dual injection. Very important. How I read this, I read by frame in different angles. Rotation angio sometimes. I see neo channels. Because 10% still you can, soft tissue tracking can be done in a chronic CTO also. And calcification and plain cine is not good. So all this, what axis you take, that depends upon your experience, but I prefer a complex CTO of when you want to switch over to retrograde and all, I prefer a 7 French or 8 French femoral. And otherwise you can do, if you want to do a contralateral injection, simple antigrade, you can choose one femoral and one radial. Definitely that choice depends on your experience. You need to keep all the guiding catheters and guide wires, balloons, and long DES, and also keep sometimes the higher size stents, like nowadays stents advantage, you can stretch a left main also 4.5, 5.5 stents are available. Prepare for the left main stenting in case a donor injection dissection comes. And always worry about the perforation, tamponade, those we can discuss that one. CTO PCA, you take minimum 2 hours each lab time. and inform the patient protocol for the dual injection, the axis sites, and the long procedure length and radiation. A good counseling, video counseling is important. Don't ignore that. So the procedures are simply antegrade or retrograde or dissection reentry. These three are there. Checklist, you should have a serum creatinine done outside, but repeat it again in your lab because other procedure must rise in the creatinine. Usually ignore that. Give them good hydration. Keep a police catheter for a complex bifemoral approach and educate the patient family about the procedure. And emergency ducts should be kept always in the lab and keep the defibrillator working. Locate the IABP or ECMO device sometimes. I never used it, but once I happened to use the balloon pump. Out of 1680 cases, I used to use my IABP in one case. And specialized CT equipment, covered stents, coils, snares, pericarditis history, all should be there. And ACT machine should be working, check it. And this is the, like you see, this is the, you thought the distal small CTO segment, but if you see the CT, the long segment calcium. So even you cross the CT, tracking the device is a real problem. Like this age is 10 years old CTO, we could do easily. Age may not be a criteria for the this thing. Like this is a tapering stump, but difficult antegrade. If it's the calcium, that's why CT scan sometimes is very important. You see here, you can see a proximal and distal alignment is not there. This is a difficult case. For learners, I think these are simple basic things we should learn, which case we should attempt. And a proximal soft tissue in a long segment CTO. It appears very simple. You see very long segment CTO with multiple lesions. And a visible distal vessel by retrograde is very important. Remember, if you don't see the distal vessel, antegrade or retrograde, don't attempt at CTO. It may be acute occlusion or see it by CT. No visible distal vessel. You see, this is very important. Rat tail sign, a good sign of success, but not all the tapered holds the truth. And bridging collaterals. If you want to do, you see the bridging distal vessel by bridging collaterals, always not a good choice because once your microcatheter is in, distal flow will stop. That's why retrograde vessel coming from the contralateral injection is, if that case is more easier rather than crossing only bridging. The side branch at CTO can guide you for IVAS guided puncture, but the side branch at the distal end can be sometimes helpful. Like this case was selected in the TCT in 2013. I have done when the Gaia wire entered in India. So distal cap bifurcation is ostial stump occlusions, very difficult cases. This needs CT angio, and mostly we prefer a retrograde approach in this, like this case. Neo channel, sometimes we cross the CTO and find a neo channel, but wire cross, balloon not crossable. So very, very difficult. Maybe a laser nowadays is useful, and otherwise the CT is very important in this. Before that you can see whether balloon can be dilated or not. ISR CTO, because the ISR, the stent edges will guide you, that's one advantage. But at the distal part of the ISR CTO is always difficult. I'm not going to touch the wires. There are many wires of polymer jacket, Gaia series, people know it now. The Gaia next series also has come. They are very good wires. Conquest Pro 12.9, everything is available in India. Many low profile balloons are there. Simple techniques for anybody learning is contralateral injection, crossing antegradely. The second thing is parallel wire, always the strong wire to be used as a parallel wire. And this is a very useful technique. If the parallel wire is long segment, hematoma not there, success rate is more. Now this IVAS guided, if a side branch is there, you can put a 20 megahertz IVAS, which is trackable across the side branch, and while pulling, you can see the CTO segment. Like you see, it is at 3 o'clock, you can see the LED stump with the wire. For retrograde, you need good planning and septal analysis, septal advancing the coursier, crossing with the wire, coursier crossing, and then you have to do externalization after reverse cut and send the CTO. This is simply, this course I am not touching. These are the important tools. This also, okay. If you have a septal collaterals, epicardial, prefer the septal collaterals. Out of, I must have done many CTOs, but I done very few, only 16 to 18 epicardial collateral, very complex. Mostly I prefer septal collaterals. Check for the collateral injury at the end, very important. And complication management of coil, mostly I use coils, but there are many methods of sealing the perforation. Pericardial stage should keep in the lab. And access injury can be avoided by using the angioseal and proglides. You can use the covered stents. But always, I never, only one case I have to send for surgery, but I always keep my surgical friend near and away. When to stop also very important. 5 gray, usually 5 gray I stop, but 3 gray is the standard what they recommend. If a procedure is finishing successful, we may stretch. And 3 times the estimated GFR is the contrast volume. And when hemodynamic compromise, never prolong the procedure. Radiation exposure is very important. You already know about it. So staged procedure asking. The staged procedures, I keep somebody tried if CTO PCI with the balloon dilatation and all, I wait for minimum 8 weeks, 2 months time, that is the standard. So there is no virtue of being a cowboy, a cowgirl. Highest risk elective coronary procedure, and should have a broader skill set, will help you identify, mitigate the risk. Continuously update likelihood of success in your mind. Stopping is not failing. Harming his patient is a failure. Thank you.
Thank you, Dr. Prakash Rao. Since we are running short of time, I'd like to invite Dr. K. Roshan Rao for his mass technique.
Can I have my slides, please? Thank you, Dr. Alkesh, and thank you all respected panelists and chairpersons. This is an acronym which I am filing for registration. So it's just making most of the misery, because whenever you are entering in on a false lumen, then is a problem. Parallel wire is a technique. It is something akin to that, which is called microcatheter assisted side tracking. So CTO, the most notorious clinical challenge is subintimal entry. Now, if you see wire inadvertently enter the subintimal space, which is called the false lumen, the microcatheter that we are using follows it. And when we withdraw these microcatheter, we lose the track, and or if we put a wire inside it, we deploy complex ADR devices, as Dr. Surya Prakash Rao rightly said that they are very rare nowadays in India because of availability of good wires and hardwares. So, or you attempt a parallel wire technique. So this malposition wire technique, microcatheter, is not a failure. In fact, it's a So the core concept of microcatheter, it is used as a scaffold. It causes stabilization, the microcatheter, because it occupies the subintimal space, so it stabilizes that space so that the space is not increased. It causes deflection because of the bulk of the microcatheter is much more than wire. So physically it deflects the second wire towards the true lumen or an intimal plane. Targeting the true lumen is easier with microcatheter occlusion of the false lumen. So this is the basis of it, and these are step-by-step technique. Basically, once you recognize a false lumen by too much wire freedom, lack of distal branches, and wide knuckle formation, and so on and so forth, we leave the microcatheters there and we do not remove it. So it stabilizes that track, and also it acts as a reference. So when we introduce a second wire, it's a dedicated CTO wire. It is a tougher wire. It has got, we do a better, small knuckle, which is 1 or 2 millimeter in length. So we direct that wire to the anticipated true lumen. The microcatheter zone is the no-go zone, which is very important. Step 5th is confirm the distal true lumen. Once it crosses the wire, then we confirm the true lumen. And then we advance the microcatheter over the second wire. the benefit, these are some cases where I can elaborate it. And this is a CT of RCA. If you look into it, looks easy. Microcatheter was crossed, and this was the wire over which the microcatheter was stretched. Then we took that microcatheter across into the PDA, and when we took a shot, it was a false lumen, and it was something we could not see any branches. It was just a subintimal. So we left the microcatheter there and passed a wire which was easily passed to the PLV. If you can see, this is a PLV, and you can see the distal flow after this. So what microcatheter does is it directs the wire towards the lumen, and it's easier to pass. So after that, this was a routine case. This was the final result. This was another interesting case, again in RCA. We were able to, it was grade 3 collaterals, and we were able to, cross the wire, and if we looked into various channels, it appears that this wire is into the true lumen, but this Gaia wire was not going through. Look at all the three views. It looks as if it is in the true lumen, but this was not going through. Then we checked out on removing the wire. You can see that the microcatheter is in the false lumen. So this, so this is a microcatheter tip, and this is in the false lumen. So I removed that same Gaia wire and crossed it and passed it across, and you can see how easily it goes. So this is how it stretches. Besides the microcatheter, this is the microcatheter, and we were lucky that microcatheter was there. We were not able to go inadvertently into the false lumen. So this is the microcatheter, and that's the wire. So that is how easily it goes. So whenever you come down to all these things, just don't remove the microcatheter, and that's the hack. Then it was a routine case, and this was the final result. Why mask trick works? Because the mechanical advantage is that microcatheter provides a right physical boundary limiting the space where the second wire can wander. Conceptually, it is very simple. It is modified parallel wire technique. With the first wire is highly visible. It is stable because it is 2 French plus, and it's a stiffer microcatheter, so it is not possible for a small wire to enter a false lumen. It has got improved vectors because of the combination of the guiding catheter exit angle and microcatheter bulk, which creates a natural deflection towards the true lumen. The fourth thing is, which is very important, that microcatheter, because being stiffer, it provides an additional guide support, so that you have a better guide support, and then you can really push the wire through. So these are the advantages. No specialized equipments are required. It's a quick bailout for a false lumen. It is unlike the parallel wire, which requires 2 wires. Same wires can be used. Microcatheter is bulkier, and so occupies the majority of the false lumen. There is a less chance of second wire re-entering the false lumen, which is the hack of MAST. And highest success rates are expected when subintimal space is small, which is important. CTO, so it is very important, once you recognize that you are in a false lumen, you don't push the microcatheter further. CTO segment is short to moderate. Vessel size, vessel course is well visualized, because good lateral injections are very important. So this is the reverse mask. I'll just summarize it, because we are not able to pass it anterogradely. We pushed a microcatheter retrogradely, and we were not able to proceed further in this course. So what we do is we push the microcatheter as far as possible, and then it was, as a landmark, we were able to cross the antegrade wire. You can see the microcatheter there is in the false lumen, and these are dual injection. After that, simple wire was, we were able to cross through, and this is what the final result looked like. So this is retro mass. The difference between the anti-mass and the retro mass is that in retro mass, you have to push that microcatheter as far as possible. So thank you. These are the pro tips, which is pitfalls is a large subintimal dissection can occur. Severe calcification, any stiffer wire will bounce back into the false lumen. Risk of extending the dissection is really well, so you have to be careful. Don't push the microcatheter too far into the false lumen. The operator pro tip in shaping the wire is very important. The second wire or the re-entry wire is shorter, more acute curve, 1 or 2 meter compared to your standard bend. This helps hooks the wire backward towards the true lumen, and also taking a support of stiffer microcatheter, which is there in the false lumen, which is easier in acute bend. So the hack is that when the microcatheter is in the false human, it can be used as a scaffold and the physical rail for the second guide wire to re-enter the true lumen. So whenever you have a microcatheter inside a false human, use a second wire, and probably it will be easier for you to re-enter the true lumen. Thank you for your kind attention. Thanks a lot.
Thank you, Dr. Roshana. If there is any question, then we can take.
Yeah.
Or else
Yeah.
we'll move on to Dr. Hetan Shah for modern CTO tools 2026. What's essential and what's hype?
Thank you. I think my previous speaker has made my job very easy. I must say thanks Dr. Sarita Rao for taking this journey of WinCar in 26 in a beautiful way and covering all the aspect of interventional cardiology. CTO considered to be a last frontier of interventional cardiology. With the advance of modern technique and all, previously we used to counsel the patient that 50% chances of opening the vessels. But now, with the new advancement of the hardware and the technology, the success rate is almost 90%. There are two types of CTOs we are facing in our cath lab. One is acute occlusion and acute on chronic in a PAMI situations, and another is a CTO. So our talk is limited to the CTO, those who are more than 3 months of old and which is not having any evidence of recent ischemia. And any CTO, once we approach, we should know the proximal cap, the body, and the distal cap. And then our anatomical understanding. That's why the CT planning is very essential in nowadays. And now we are going to be in an era of AI. I think that also will make us job more easy to know what we are going to face. So first questions in our toolbox before we open, whether the tissues is viable, what is the JCTO score, and what is the stop point. That we should know. Second thing is, as I think everybody knows the JCTO score, but if score is more than or equal to 2, then operator should be aware of all the important hardwares, and if it is more than 3, then you should take a risk-benefit ratio. So while reading the CTO, you should know what is the proximal cap, what is the length, the distal vessels, and the colon. So what are the essential tools? They are obviously the imaging is the first, the access site, the guide wire, the microcatheters, and the bailout tool. As an operator, one should know the radiation safety. If your procedure is going to last for more than 3 hours, your gray area is almost more than 5, then you have to stop it. But you always keep a fluoro save, the low collimations, and your frame rate to be adjusted to protect your radiation exposure. And while opening the toolkit, you should know the pre-lesion, what are the states, the guides, and the lesion crossing and the post-lesion crossing. The sheets, I think it is very important. Always prefer a femoral route than the radial. Radial, if you want to use, only the 6 French and the sheetless guide you can use, where you can get a good inner lumen. And the femoral approach is always preferable, and you can have a room for 7 or 8 French where you can park your microcatheter and balloon together. The guides, if you are doing the right side, side hole is better. But unprotected left vein, don't use the side hole because it gives you a false alarm of having a blood pressure being on the safer side. So coaxiality, the guide catheter should have a mother access for mother and child, even the granddaughter. The 8 French guide having a mother and child, and you want to use a guideliners, the anchoring balloon, it should accommodate. So your support has to be very well. Otherwise, if you are crossing and at certain point everything is back out, then you are waste of time. The dual injections for planning, and you should know how to perform the dual injections. And wait the CNA till the contrast. And the collaterals, I think we had already discussion that septals are always better than any other, and you should know the risk benefit. Now about the guide wire crossing, the workhouse wire, the polymer jacket, and the what are the different higher strength wire you should know. The basic structures I think everybody knows, but our journey, how you can escalate the wire. It's starting if the lesion length is less than 20, there is no ambiguous proximal cap or good quality distal. You start with the filter XT and then you can escalate. But every operator should have a knowledge of how to handle the hard end of the wire and while parking at the distal end. Once you cross the CTO, put a microcatheter and change over the wire. So you are not having a distal perforation. The polymer jacket wire and the penetrations wires are of a different models are available, but always keep in mind the if you are dealing with the higher end than advanced steering wires like a Gaia family, but while you are using that, you should have a very gentle movement and see the distal where you are going. And the collateral wires, obviously, the Sion or SUO wire are for the retrograde path. Different technique, I think the previous speaker has done the job. But if the balloon is, if your lesion is uncrossable with the wire, with the balloon or undilatable, then you have to use a different, the parallel wire technique. You can use a NC balloon, you can do a granuloplasty. You can just install balloon, you can inflate, and then you can do a debulking. But there is a role of IVUS or imaging and a retrograde technique. That I won't go into the detail about this, but the microcatheter obviously has changed the way, because there are two different type of microcatheters available, which are like a fine cross or a double lumen. They are like only for the push phenomena, but now the turnpike and the twin pass, you can rotate the things in the tortuous pathways also. And a dual lumen, it gives you a more precise landing of the at the lesion side, as well as you can second lumen you can use for your wire manual. These are the standard technique, the integrate wire escalations, dissections, and retrograde wire escalations and dissections. So as we discussed the microcatheter, but I would like to add here the stingrays and crossbows. They are the game changer for the more for the ADR technique, where you want to dissect, and they require a high skill. The crossbows is more of a spinning, and the stingray is more of a require a precise planning and a dual lumen balloon, where you can re-enter the true lumen while subsequently planning. And as I said, the IVUS and other thing, imaging, gives you a better idea about your lesion crossing. And one should have a toolkit. Any CTO operator should, without this toolkit, is not a correct way. The snare, the covered stent, and the pericardial synthesis device. So I think this is a global algorithm everybody knows. But lastly, I would like to say that before you open your tool bag, you should know your JCTO score, the stop point, and what are the standard equipment available in your cath lab. And this is, I end my talk over here. As a woman cardiologist, we had also gone through a long journey, but we should keep such meeting and keep our resilience, and we can shape the women's heart health and the cardiology in a better way. Thank you.
Thank you, Dr. Adhan. Now we'll close the session, and I invite all the speakers and chairperson to come for a group photograph.